Let's look at the warm-up for Micro 11. First question, what molecule does the Golgi apparatus add to proteins in order to direct those proteins to the lysosomes? Well, it's mannose-6-phosphate. Next, what are the signs of right-sided heart failure? So we talked about how left-sided heart failure causes pulmonary symptoms. Well, right-sided heart failure is going to cause peripheral signs and symptoms like lower extremity edema, jugular venous distension, and maybe hepatosplenomegaly. All right, that's it for the warm-up, so let's get started with the lecture.
Hey guys, Dr. Carmichael here. We'll be going over Step 1, Micro 11, and today we're going to be talking about penicillins. Bacteria have cell walls, and that cell wall is composed of peptidoglycan, which, as the name implies, is a bunch of glycan that's bound together with peptides. There's a group of antimicrobials that work by inhibiting the synthesis of the bacterial cell wall, and strangely enough, they are called cell wall inhibitors. So let's talk about the prototype antibiotic cell wall inhibitor, penicillin. Now, what's the mechanism of action? They have three mechanisms. First, they bind to penicillin-binding proteins. The penicillin-binding proteins are involved in the synthesis of peptidoglycan, which, as I just mentioned, is what makes up a great deal of the cell wall. So, by binding these penicillin-binding proteins, the cell wall can't be created, and this leads to cell lysis. The second mechanism that the penicillins inhibit the formation of the cross-linkages between the peptidoglycan chains. This leads to a weak cell wall. The third mechanism is not as well understood. Many bacteria produce autolysins that remodel the bacterial cell wall. When the cell wall is weakened or absent because of penicillin, these autolysins will damage the bacteria. Penicillin may even upregulate these autolysins, which again lead to more bacterial death. Because of these actions, penicillin is considered a bactericidal antibiotic. You may hear the penicillin is a beta-lactam drug. What does that mean? There are several antibiotics that contain a beta-lactam ring as part of its core structure. So that's why they're called beta-lactam drugs. And we'll go over that in just a little bit. Penicillins come in two forms, penicillin G, which is the IV form, and penicillin V, which is the oral form. Don't get confused, V goes with the oral, not with the IV. Clinical uses. Most of the time, penicillin is used against gram-positive organisms like strep pneumoniae, strep pyogenes, actinomyces. Group B strep is also covered, and penicillin can be used to prevent GBS neonatal infections. During labor, penicillin can be given to mothers who are group B strep positive. Also, think of spirochetes, so think of syphilis. This is one of the few diseases where penicillin is the #1 antibiotic to use. It also covers some gram-positive rods like Clostridium, Listeria, and Bacillus. It can also cover some gram-negative cocci, namely Neisseria. Now, it is not penicillinase resistant. We will talk about penicillinase here in a little bit. The most common toxicity is a hypersensitivity reaction. So you will often hear of people who are allergic to penicillin. Now there's a lot more people who think that they are allergic to penicillin than there actually are. But it's still the #1 major adverse effect. Rarely patients can develop hemolytic anemia and thrombocytopenia. Let's move on to our next group of cell wall inhibitors, methicillin, nafcillin, oxacillin, and dicloxacillin. These fall under the category of penicillinase-resistant penicillins. What about their mechanisms of action? Well, it works almost the exact same way as penicillin. It's still attacking the cell wall, but it's penicillinase-resistant because of a bulkier R group. So what is a penicillinase? A penicillinase is a type of beta-lactamase, and sometimes you'll hear those two used interchangeably. Penicillins are made up of the isolidine ring, and sometimes called a beta-lactam ring. Coming off of the beta-lactam ring is another thing called the R group. So penicillinase hydrolyzes the beta-lactam ring of many penicillin-like drugs, thus making them ineffective. That R group is what's different in these newer drugs, methicillin, nafcillin, oxacillin, and dicloxacillin. Because of the bulkier R group, the penicillinases can't get to the beta-lactam ring, so they get very descriptive name, penicillinase-resistant penicillins. Now, where do bacteria produce the penicillinase? Many gram-negative bacteria produce it in the periplasm, and they are coated by the plasmids. So the periplasm is where the resistance for penicillin resides in these bacteria. Now, another route of penicillin resistance is alteration of the beta-lactam target, so the penicillin-binding proteins. If the penicillin-binding proteins are altered in some way, then the penicillin can't bind to them and they can't disrupt the cell wall. So let's talk a little bit more about clinical use of these penicillinase-resistant penicillins. Most importantly, they kill Staph aureus. These meds are sometimes referred to as the anti-staphylococcal penicillins. We have to make a distinction here. Oftentimes when people talk about Staph aureus clinically, there are two different ways of referring to it. There's MSSA, methicillin-sensitive Staph aureus, and there's MRSA, which you will probably hear more about than MSSA. This is methicillin-resistant Staph aureus. And MRSA is a resistant bacteria because of an alteration in penicillin-binding target site. So again, if you can't grab onto it, you can't kill it. So if a patient has MSSA, does that mean that we have to use methicillin to treat the patient? No. Try not to get confused by this. We actually don't use methicillin clinically because of its toxicity. Methicillin can cause interstitial nephritis, so we only use it to determine resistant strains of staph. So if a patient has Staph aureus that is sensitive to methicillin, you could use nafcillin or dicloxacillin, but you wouldn't actually use methicillin. The other toxicities for the rest of the anti-staphylococcal penicillins are pretty similar to penicillin, hypersensitivity reactions. So let's talk about ampicillin and amoxicillin. These are termed the aminopenicillins. So how do they work? Well, basically the same way as the penicillin again, but they do have a wider spectrum. They are still penicillinase sensitive, so the penicillinase will still make these drugs ineffective. Look in your study guide. What are the clinical uses for ampicillin and amoxicillin? This is worth writing down because it'll help you remember this. These are the extended spectrum penicillins. So gram-positive bacteria are covered, but in addition to gram-positive bacteria, now we see some gram-negative coverage like gram-negative rods. There is a mnemonic that's been used for years called HELPS. HELPS stands for Haemophilus influenza, E. coli, Enterococci, Listeria, Proteus mirabilis, and Salmonella and Shigella. So what common infections are caused by E. coli, Proteus mirabilis, and Enterococci? Well, often we see them in UTIs. So the extended spectrum, the aminopenicillins, can be used for UTIs. They are usually not the first line, but you can use these for urinary tract infections. What about E. coli and Listeria? Now, where do we see these? Well, these are neonatal infections, so we use ampicillin in those situations. This is the IV form of the aminopenicillins. In newborns, ampicillin is used in combination with gentamicin or cefoxitin for better coverage, especially when the babies are very sick or septic. Now, amoxicillin has greater oral bioavailability than ampicillin. Ampicillin is more often used in an IV form. There is a PO form, but we don't use it very often. When it comes to toxicity, again we see this as a hypersensitivity reaction, so that penicillin allergy tends to fall along with the aminopenicillins as well. One interesting phenomenon is that ampicillin or amoxicillin has a rash. So this is referring not to just a hypersensitivity reaction, it's referring to a scenario where if a patient has mononucleosis and you give them aminopenicillin, they'll get a full body rash. So patients will think that they are allergic to amoxicillin, but when they get this big rash while they have their mononucleosis, you can be fooled into thinking they have this allergy when it's really just a reaction from the mono and the aminopenicillin. So why would a clinician give amoxicillin to someone with mono? Well, they shouldn't, but mono produces a pharyngitis similar to strep throat. So maybe you see a nasty pharyngitis and you give an amoxicillin without testing for strep, and that's how that scenario occurs. Just as a bonus question, what causes mononucleosis, or what is the most common cause? That's going to be Epstein-Barr virus. Just remember it. Sometimes we like to combine aminopenicillins with penicillinase inhibitors to enhance their spectrum. A beta-lactamase inhibitor or penicillinase inhibitor is a great addition to these drugs because then the antibiotics have a better chance to kill resistant bacteria. These are not used alone, but are combined with some of our penicillin drugs to make them tougher antibiotics. They include clavulanic acid, sulbactam, and tazobactam. Clavulanic acid and sulbactam are the two most commonly used. Clavulanic acid comes with amoxicillin, is a common combination, and is used to fight resistant causes of otitis media. Ampicillin can be combined with sulbactam. This is an IV medication and often used in surgery to help with surgical infections. Ticarcillin can be combined with clavulanate, and piperacillin is commonly combined with tazobactam. Speaking of which, let's move on to the carboxypenicillins. This is ticarcillin, carbenicillin, and piperacillin. These are called the anti-pseudomonal antibiotics, and their mechanism of action is again very similar to penicillin. They are still attacking that cell wall. We call these the extended spectrum penicillin drugs. So for the clinical use, shocker, they're used for Pseudomonas. They also will work against gram-negative rods. They are susceptible to penicillinase, so sometimes you will add clavulanate or tazobactam. With these, the toxicity is again hypersensitivity reactions like all the other penicillins. Now for a quick review, look at your study guide. Which penicillin drug would you give for the following infection? For syphilis, we give penicillin G. UTIs, you would use amoxicillin because it has better gram-negative coverage. Pseudomonas, you could use ticarcillin, carbenicillin, or piperacillin. In neonatal infections, ampicillin, usually combined with gentamicin. So let's go through the answers at the end of session quiz in your study guide. Your first question: what organisms can be treated with ampicillin or amoxicillin? The aminopenicillins have gram-positive coverage like most of the other penicillin-like drugs, but they also have gram-negative coverage. And remember, your HELPs stands for Haemophilus influenza, E. coli, Enterococci, Listeria, Proteus mirabilis, and Salmonella and Shigella. Next, which three penicillins discussed can be used to treat Pseudomonas infections? Ticarcillin, carbenicillin, and piperacillin. These are the anti-pseudomonal penicillins. Next question: what are the two different mechanisms of resistance for bacteria against penicillin agents? Bacteria can produce beta-lactamase, which hydrolyzes the beta-lactam ring, and the other mechanism is alteration of the penicillin-binding proteins. What are beta-lactamase inhibitors? Sulbactam, clavulanic acid, and tazobactam. That's the end of session quiz, guys. We'll see you at the next one.
What is the major cause of bacterial resistance to penicillin? You. Yes, you. I'm talking to you. The major cause of penicillin resistance is beta-lactamase production. Pay attention. I'm not doing this just to hear myself talk. I do this because I love teaching.
Let's go over the warm-up review. First question: what's the difference between a case control study, a cohort study, and a clinical trial? And which studies use odds ratios and which ones use relative risks? So both case control studies and cohort studies are observational studies. You're not intervening, you're just observing. A case control study starts with a diseased population or a population with a specific outcome and then looks for exposures. A cohort study starts with an exposed population and then looks for a specific disease or outcome. And a clinical trial is where you do some kind of intervention, a medication or a procedure or even just education or counseling, and you're evaluating prospectively to see if your intervention has made a difference. So case control and cohort studies are purely observational, but a clinical trial is experimental. It's a prospective experimental study. And then for the second part of the question, case control studies allow you to generate odds ratios, and cohort studies allow you to generate relative risks. And the last question, which type of vasculitis is associated with each of the following statements? So necrotizing granulomas of the lung and necrotizing glomerulonephritis is going to be granulomatosis with polyangiitis, or Wegener's granulomatosis. The next one is necrotizing immune complex inflammation of the visceral and renal vessels. It's going to be polyarteritis nodosa. Young Asian women should make you think about Takayasu arteritis. Young asthmatics is going to make you think about eosinophilic granulomatosis with polyangiitis, or the older name is Churg-Strauss syndrome. Infants and young children involving the coronary arteries is Kawasaki disease. The most common vasculitis is temporal arteritis, also known as giant cell arteritis. And then the one associated with hepatitis B infection is polyarteritis nodosa. Now let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on cephalosporins. Now, sometimes while studying for Step 1, you might be tempted to think, man, this is some useless, esoteric garbage that no one really needs to know. But come on, today we're going to learn that cephalosporins increase in gram-negative coverage as you increase in generation. You're actually going to use that someday. And are you trying to tell me that knowing that introns or intervening non-coding segments of DNA is a waste of your life? Well, okay, you kind of got me on that one. That might be kind of worthless. But since you're watching this video, you now know that my favorite cookie is a chocolate chip cookie. See, this isn't a waste of life. This is an opportunity to make a cookie buddy. Now go buy me some cookies. All right, so today we're talking about cephalosporins. So these are very close cousins to the penicillin. So luckily for you, you get to use some of the knowledge that we just gained from the last lecture for the cephalosporin. So in general, this is a class of antibiotics that are active against the cell wall of bacteria, just like the penicillins. So they will bind to penicillin binding proteins, and they're going to inhibit one of the final steps in the synthesis of peptidoglycans. So without peptidoglycans, you can't have a functional cell wall. Therefore, that's going to result in cell lysis. Now again, like the penicillins, they are considered bactericidal, but unlike the penicillins, they are less susceptible to the penicillinases. Now, cephalosporins are great against gram-positive organisms, but there is a lot of gram-negative coverage as well. But that gram-negative coverage will vary depending on the generation of cephalosporin. Now, there are 5 generations of cephalosporins, and as a general rule, as we increase in generation, we're going from that first generation to the 5th generation, we increase the gram-negative coverage, but you will also unfortunately decrease the gram-positive coverage slightly as well. So let's go through these generations. I'm not going to cover every single cephalosporin in the world, but I will cover the most commonly used drugs and those that will most likely will be seen on Step 1. So first, the first generation of cephalosporins include things like cefazolin and cephalexin, the two most commonly used ones. So these drugs will cover gram-positive cocci, but also remember that they will cover some gram-negatives as well. One mnemonic that's been used forever is PEK, P-E-C, big K, and that stands for Proteus mirabilis, E. coli, and Klebsiella. Now, what are the clinical uses for our first generation cephalosporins? And this will also kind of cover for second generation as well. These gram-negative bugs that we just mentioned are commonly found in urinary tract infections. So these are commonly used to treat acute cystitis, even UTI prophylaxis as well. Especially we use cephalexin a lot for that purpose. Now, sometimes they're used for upper respiratory tract infections because they cover gram-positive cocci. They can be used like the aminopenicillins for prophylaxis against viridin strep bacterial endocarditis. So patients with mechanical heart valves need to take antibiotics to prevent bacterial endocarditis during those dental procedures. So you can use your first generation cephalosporins. Now, having said that, amoxicillin is used first line in most cases. Cefazolin is also used perioperatively to prevent post-op surgical infections like MSSA, the methicillin susceptible Staph aureus. Next, let's move on to our second generation. This includes things like cefoxitin, cefaclor, cefuroxime, cefprozil. Now, again, these will cover most of our gram-positive cocci that were seen in our first generation, but then we're going to add on to our gram-negative mnemonic as well. So not just PEK, remember that was P-E-C-K. Now it's HINS PEK, and remember the S at the end of HINS. We tend to forget that one. So let's go through what HINS is all about. So HINS is going to stand for Haemophilus influenza, Enterobacter, Neisseria species, and Serratia marcescens. Then you're still going to keep the PEC, so that's not going well. So you're still going to have your Proteus mirabilis, your E. coli, and your Klebsiella. So remember those. HINS, PEC is a great mnemonic. Now the first generation was just PEC, though Neisseria species is on the list. We do not use the second generation cephalosporins to treat gonorrhea, so urethritis. We're not going to use that. There's a growing resistance in this drug class to urethritis and gonorrhea. So just to recap again, we're losing just a little bit of gram-positive coverage, but we're gaining more gram-negatives. Let's move on to third generation. This includes things like ceftriaxone, cefotaxime, ceftazidime, and cefdinir. So they will be very useful for more serious gram-negative infections. Now remember, we're moving into greater coverage of our gram-negatives. This generation will cover serious gram-negative infections that are resistant to other beta-lactams. So we're covering E. coli better, Proteus mirabilis, Klebsiella, Enterobacter, Serratia, Citrobacter we're adding on here, Neisseria, H. influenza, but just kind of more serious infections. The third generations are the drug of choice for things like gram-negative meningitis, so very serious infections. There is less gram-positive coverage overall, but you can still cover strep pneumoniae. So remember, strep pneumo still gets caught by the third generation, where a lot of our other gram-positives are no longer being covered. Therefore, ceftriaxone is often given to patients with pneumonia, but you do have to add on something like azithromycin or a macrolide to cover atypical bacteria. We'll talk about that in a little bit here as well. Now, ceftriaxone, again, has the longest half-life and can be given IV or IM once or twice daily. So this is the drug of choice to give for something like Neisseria gonorrhea. All you have to give is one IM shot, and that should take care of that cause of urethritis. Ceftriaxone is also excreted in the bile, therefore it's a great antibiotic to use in patients with renal failure. Now another unusual one, ceftazidime, another third generation, can also cover Pseudomonas, and that is one of the few cephalosporins that can cover Pseudomonas adequately. Cefdinir is another great third generation that I use all the time, and it's indicated for resistant cases of otitis media. So if a child has otitis media that does not resolve with amoxicillin, then you can consider using Cefdinir as the next drug of choice. One way to remember this is by spelling it Cefdinir, so E-A-R at the end there. That's a good way to remember otitis media. Fourth generation. Now the only fourth generation I think you should probably know is cefepime. So this is a great broad spectrum drug. It's kind of a big gun. It breaks the rule of decreasing gram-positive coverage. So it actually still keeps a lot of the gram-positive coverage that we saw in our early generations, and it has increased activity against Pseudomonas as well. So it's a great gram-negative, gram-positive, and Pseudomonas drug. Great all-around broad spectrum. And then we have fifth generation. So this is a very new generation of drugs, and actually not everyone agrees that they should be called fifth generation cephalosporins. Ceftaroline is the only one that I want you to know. It's also a very broad spectrum like cefepime, but it also covers, and this is how it's very novel, MRSA, so methicillin-resistant Staph aureus. Quite novel for any cephalosporin. Ceftaroline does not cover Pseudomonas, so that's kind of its one hole. It's being used for community-acquired pneumonia and complicated skin infections, including MRSA skin infections. All right, guys, so let's go over some of this again in a Lewis Notes. All right, everyone, we're talking about cephalosporins here. Let's go through the spectrum of these cephalosporins and then connect some of these to the actual names themselves, because that's kind of a tricky part, knowing which one goes with which generation. So first we have our first generation. Remember our mnemonic here was PEC. And remember the PEC is going to stand for Proteus, E. coli, and Klebsiella. And then our second generation is going to add on to that. You're still going to have the PEC, but then you're going to add on the HINS. So the HINS is going to go for H. flu, then Enterobacter, Neisseria, and then Serratia. Now, so you can't forget that the second generation still has the P's up there. Now, there's also going to be gram-positive coverage for both of those as well, so don't forget the gram-positive coverage. Now, we start to lose some of that gram-positive coverage when we get to the third generation. But so things you're going to still have, though, you're still going to have strep pneumo. So remember that you're going to get strep pneumo with our third generations too. But your gram-negatives are going to be better coverage, so you can use for those trickier gram-negative bad diseases. And then for our fourth generation, remember it's a big gun. Broad gram-negative, broad gram-positive, but also the other thing to remember is going to be Pseudomonas. So you have to add on Pseudomonas to our 4th generation. Then our 5th generation, our brand new, spanking new guy that we're not using quite so much yet, but we probably in the future. Remember, its big claim to fame is that MRSA is also covered. So next we're going to check to see which one of these cephalosporins goes with each generation, because that's kind of the tricky part here. So first we have Cefprozil. Cefprozil is going to be one of those 2nd generation cephalosporins. Cefdinir, that one is 3rd generation. Remember, I like to use those for my resistant ear infections. Cefepime, our big gun. Cefepime is 4th generation over here. Remember, it's got that broad spectrum. Cephalexin, commonly used for things like UTIs. We use that as our 1st generation cephalosporin. Ceftriaxone, another great 3rd generation cephalosporin. That comes in IV and IM. We use that all the time in the hospital. You can also use it for STDs and that sort of thing. Ceffuroxime is going to go into our 2nd generation right here. And cefazolin is another 1st generation. We're going to move that one over there. And then ceftaroline or ceftaroline is going to be moved over here, our brand spanking new 5th generation MRSA killer. All right, guys, so if you can remember your mnemonics here and then remember sort of which one of these go with each generation, I think you'll do fine. All right, so one other good bit of information is what bacteria cephalosporins are not good at covering. And there's another good mnemonic that's been used for a long time, LAME, L-A-M-E, which stands for Listeria, atypicals, and we're talking about atypicals in regards to pneumonia. So it's mycoplasma and chlamydia. So they're not going to cover atypicals very well at all. MRSA is another one, and enterococci. Now, the one exception is that very new 5th generation ceftaroline. It covers that MRSA. Now, how would this gap in coverage also affect your treatment of community-acquired pneumonia? We talked about this a little bit before. If you have a patient in the hospital with pneumonia, you can use something like ceftriaxone, great for strep pneumo, but you're also going to need to add on something like azithromycin to cover the atypicals. How about some toxicity? Again, these are pretty well tolerated medicines. We will see some hypersensitivity reactions, maybe similar to penicillin. There actually is some cross hypersensitivity with penicillin. So there is some worry that if you are already allergic to penicillins, whether or not you should take a cephalosporin either. So it's somewhere between 5 and 10% will have that cross reactivity. Now, some will argue that it's higher than that. The most recent data that I've seen has shown that most people can comfortably take cephalosporins if they are allergic to penicillins, unless they've had an anaphylactic shock reaction or major problems. Then I would probably be a little more cautious. But I think you can still take them even if you do have a mild penicillin allergy. Now, for years we taught that you can get increased nephrotoxicity if you combine cephalosporins with aminoglycosides, something like gentamicin. New data suggests that this isn't the case. You'll probably still see that in some review books. You can also get a disulfiram-like reaction with ethanol with certain cephalosporins as well, but again, this is quite rare. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those yourself, and then we'll go through them together. First question, which generation of cephalosporin would you choose to use for the following infections? So first we have a UTI prevention. So you could probably use a 1st or 2nd generation good gram-negative coverage with those. Serratia UTI, you're probably going to want to use a 2nd generation for that one. Neisseria meningitis, remember what was the one we're going to use for that? Probably a 3rd generation, something like ceftriaxone. Pseudomonas, so this is a good one to remember. We have 2 good examples here. We have ceftazidime, which was a 3rd generation. Then you can also use cefepime, which was a 4th generation. Resistant otitis media, remember this is 3rd generation. Cefdinir, try to spell it with an ear at the end, and that's the way I remember that one. Next, classify the following cephalosporins as either 1st, 2nd, 3rd, 4th, or 5th generation. So this is probably one of the hardest parts because all these sound the same, but you do have to memorize them. So first we have cefepime. Remember that was our big gun, 4th generation. Cephalexin, 1st generation. Ceftriaxone, 3rd. Ceffuroxime, that one's a little bit tougher, 2nd generation. Ceftazidime, another one that might be tricky to remember, 3rd generation. And then our new crazy one, a ceftaroline, that's 5th generation. Next, what is the mechanism of action of the cephalosporin? So remember, very similar to penicillin. They're going to bind to penicillin-binding proteins. Thus, they're inhibiting the synthesis of cross-linking of peptidoglycans, and peptidoglycans are critical components of the bacterial cell wall. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question. The results of a particular test show a normal Gaussian distribution with an average value of 35 and a standard deviation of 4. So what percentage of people scored in the interval from 31 to 43? Well, to figure this out, you have to know that by definition, 68% of the scores will be within one standard deviation of the mean, or the average score, and then 95% would be within 2 standard deviations. So a standard deviation is made up of both one negative and one positive standard deviation. So one positive standard deviation would be half of 68%, which would be 34%. And 2 positive standard deviations would be 47.5%, or half of 95%. So the interval you're concerned with in this question is from 31 to 43, with 35 as the average, or mean, and then a standard deviation of 4. So from 31 to 35 is one negative standard deviation. So that's half of 68, or 34%. So 34% of the scores are going to be between 31 and 35. And then from 35 to 43 is 8 points, which is 2 positive standard deviations, which again is half of 95%, or 47.5%. So 47.5% of the test scores will be between 35 and 43. So to get your final answer, you add 34% plus 47.5%, and that gives you 81.5%, which is your answer. Next, a small study of USMLE test takers for a particular school reveals scores of 225, and so on. You can read those on your own. The average score is 232. So what's the mean, the median, and the mode for these values? Will this create a positively skewed curve or a negatively skewed curve? So let's start with the mean. Well, the mean is the average, right? And they give you that, but even if they didn't give it to you, you just add up those values and then divide by the number of values. So the mean is 232. The median divides the frequency of distribution in half. So the median here is going to be 229 because half of the values are above 229 and half are below 229. Then the mode is the value of greatest frequency, which in this case is 225. So in this instance, the mean is greater than the median, and the median is greater than the mode. So this is going to be a positively skewed curve. So this is the type of biostatistics stuff that you really need to know how to do. The last question, which organisms cause infective endocarditis? So the big ones you need to think about include Staph aureus, which is most common, Viridan streptococci, Enterococci, Staph epidermidis, and then another one is Strep bovis, which is associated with colon cancer. Then you also have the Hasek bacteria, which include Haemophilus species, Actinobacillus species, Cardiobacterium, Eikenella, and Kingella. And then getting into the really rare ones, you have things like Coxiella burnettii, Bartonella species, and Brucella species. That's it for the warm-up. Let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on other cell wall inhibitors. Calling these drugs other cell wall inhibitors seems kind of snooty, kind of like high school. Ew, aztreonam is one of those other cell wall inhibitors. Don't talk to it. I heard it doesn't even cover gram-positives. Ew. Yeah, but I bet those other drugs don't even care. They're probably emo, kind of listening to The Cure all day type of drugs. All right, let's get going. So some of these drugs aren't used that much anymore, but some are still very important, especially with some of our most severe infections. And we're going to start off with aztreonam. So what's the mechanism of action and clinical use for aztreonam? So aztreonam is a monocyclic beta-lactam, and one of its benefits is that it's actually resistant to beta-lactamases. Now it inhibits cell wall synthesis and it binds to penicillin binding protein 3. Now one way to remember this is to spell it as threonam for that penicillin binding protein number 3. Now it is synergistic with aminoglycosides. So if you're using aztreonam together with an aminoglycoside like say gentamicin, you get even more killing ability. Now there is no cross allergenicity with penicillin, which is really nice. Now next, when are we going to use this aztreonam though? Well, I like to think of this medication as an aminoglycoside pretender. It's not an aminoglycoside, be clear about that, but it sure does act like one. So the spectrum is very similar to the aminoglycosides, gram-negative primarily. So that's going to include things like E. coli, Klebsiella, Pseudomonas even, and Serratia. Now there is no activity against gram-positives or anaerobes. You don't want to use it for those types of problems. So for penicillin allergic patients and those with maybe renal insufficiency who can't tolerate the aminoglycosides, you might want to think about things like aztreonam. You don't see this, unfortunately, used all that often. Now for toxicity, this is another great thing. It's usually pretty non-toxic, maybe a little GI effects, so it's actually not a terrible medication in general to be tolerating. Again, no cross-sensitivity with penicillin, so you can use them in place of penicillins when appropriate. Let's move on to the carbapenems. So the carbapenems, this is going to include imipenem with cilastatin, meropenem, ertapenem, and doropenem. Now, imipenem and meropenem are going to be the most commonly used drugs. Now think of these as like really big gun drugs. These are very powerful antibiotics, very broad spectrum drugs, and they are beta-lactamase resistant as well. They again work by binding to penicillin binding proteins. Now one important fact is that imipenem is always combined with cilastatin, and that's because the cilastatin is an inhibitor of renal dehydropeptidase 1. Because of cilastatin, you get a decrease in the inactivation of the imipenem in the renal tubule. So without the cilastatin, that imipenem becomes really ineffective. Now for coverage, these drugs again have a very broad spectrum: gram-positive cocci, gram-negative rods, anaerobes, even Pseudomonas. Now clinically, it's often used for empiric treatment of very life-threatening infections. So we use these drugs if someone comes in and they are sick. Maybe they're septic, maybe you don't know exactly what's going on. Well, you might want to use one of these medications because it's going to hit almost everything. Now, it won't cover MRSA. Therefore, sometimes you might want to combine an MRSA medicine like vancomycin and add that onto a meropenem or an imipenem with cilastatin. These drugs are also very good for covering Pseudomonas in general, so you don't have to add on an additional Pseudomonas drug with someone who's really sick and you don't know why. Meropenem has a reduced risk of seizures and won't get inactivated in the renal tubules, even in the presence of that dehydropeptidase. Now for toxicity, there is a few, especially with imipenem. You got to think about GI distress, skin rashes, and also some CNS toxicity as well. Let's move on to vancomycin. So what is its mechanism? Like the other meds we've talked about so far, vanc is inhibiting cell wall synthesis, but it's not binding to penicillin binding protein, so that's how it's a little bit different. It's going to inhibit cell wall mucopeptide formation by binding to the D-ala moieties of the cell wall precursors. So it's inhibiting cell wall glycopeptide polymerization, and it's also considered bactericidal. Now for its clinical uses, vancomycin will only cover gram-positives. Now originally, it was actually not that useful of an antibiotic because it has actually pretty poor oral bioavailability, and it again can only be used IV. Now we have much more convenient medications to kill gram-positive organisms, so why do we use it now? Well, the answer is the growing problem of methicillin-resistant Staph aureus, or MRSA. Now vancomycin continues to be pretty effective against that MRSA. So anytime you're worried about an MRSA infection, it's serious, vancomycin is generally going to be used. Now it can also be used for enterococci, though there are some resistant enterococci infections. We do worry about VRE becoming a more common bacteria. Now, vancomycin can also be used to treat Clostridium difficile, which is a major cause of pseudomembranous colitis. So this is actually a pretty interesting scenario. So most of the time, as we just mentioned, IV vancomycin is what we're going to use to treat infections. Well, this is an instance where we're actually going to use oral vancomycin. So oral vancomycin is not absorbed very well in the GI tract, so it stays in the GI tract, and that's actually pretty good in this case. It's going to be killing off our C. diff that's in the colon. But we don't actually use vancomycin very often for C. diff. Instead, we're going to use metronidazole. Now we want to use that vanc really only when we need it so we don't develop more resistances. Also, we use this for a coag-negative staph endocarditis. So staph epidermidis is a common and pretty normal bacteria on the skin, but it can cause endocarditis if it travels to the heart. This bacteria tends to affect the right side of the heart more often, so we will use vancomycin in that case as well. And now toxicity, so high yield stuff here. There's a mnemonic NOT, N-O-T, that's going to describe our toxicity with vancomycin. That's going to stand for nephrotoxicity, ototoxicity, and thrombophlebitis. So NOT, N-O-T, nephro, oto, thrombophlebitis, remember those. Now the other pretty high yield interesting thing is what's called red man syndrome. So this is a diffuse flushing of pretty much the entire body that can be pretty uncomfortable. Now this is due to non-specific mast cell degranulation. It's actually not an IgE-mediated allergic reaction. Now, to avoid the red man syndrome, you can pre-treat with antihistamines because this is just a large release of histamine. Also, you'll want to slow down the infusion. So, if someone gets red man syndrome, are they allergic and should they avoid vancomycin in the future? And the answer is no. Really, you can just restart the medication almost immediately, but you do need to let the symptoms kind of die down, restart with a slower infusion to keep that vancomycin going. So it's not that big of a deal, but red man syndrome is pretty testable on your test. Now for resistance, another good thing to know. The resistance to vancomycin occurs with amino acid changes of the D-ala to D-ala-D-lac. All right, guys, so before we get to that end of session quiz, let's do some reviews with another Lewis Notes. All right, everybody, welcome to another Lewis Notes, and we have three medications here, and sometimes it's kind of hard to remember some of the details, especially the mechanism of action in some of these things. So let's go through the high-yield stuff for this lecture right here. So we have aztreonam, the carbapenems, and vancomycin. So the first one, we have bind diala. Remember, that's going to be the mechanism of action of vancomycin. Binding to protein protein number 3. So that one is a little bit more specific to aztreonam. Remember, the penicillins are all going to bind to that penicillin binding protein. And that does leave us kind of more at the more general PBP on carbapenems there. Gram negatives only. So this is going to go towards our aminoglycoside pretender, the aztreonam. Remember, you can't use that for any of the gram positives. Now over here we have MRSA and enterococci. Anytime you hear MRSA, you should always automatically start thinking about vancomycin. No renal involvement is going to go over here with our aztreonam. So remember, you don't have to worry about being penicillin allergic, any cross-reactivity there, and great medication. Very little toxicity there at all. Nephrotoxicity, remember that's going to go with vancomycin. Thrombophlebitis is going to go over here too. Remember that's part of our pneumotic knot. The only one we're missing here is ototoxicity. And then the last thing here, we have very broad spectrum. So your big guns here, your carbapenems, they're going to get your gram positives, your gram negatives, even your anaerobes and even Pseudomonas as well. So great broad spectrum antibiotics. You can use that for your really, really sick patients because it does have some toxicities. All right, so that's going to be the highest yield stuff that you need to know for these three meds. All right, now it's time for that end of session quiz. Try to answer those questions on your own and then we'll go through them together. First question, what cell wall inhibitor matches the following statement? First one is can cause red man syndrome, that's going to be vancomycin. Aminoglycoside pretender, that's going to be our aztreonam. Inpatient treatment for MRSA, that's going to be vancomycin again. Hospitalized patient with new gram-positive cocci and clusters in the blood, you're probably going to use vancomycin again because we presume this is probably going to be Staph aureus, that clusters, that gram-positive clusters, which again you have to always assume is methicillin resistant. Next we have treatment of C. diff colitis, that's going to be vanc. Now remember, the drug of choice is probably going to be metronidazole, but the question is asking for a cell wall inhibitor. So that's oral vancomycin, which is really only used if metronidazole fails or they're intolerant to that one. Broad spectrum coverage for appendicitis. So in a serious infection, you might want to use something like imipenem plus celastatin or meropenem. Cell wall inhibitors effective against Pseudomonas. So we're actually having to go back a little bit in our thing. You have to use cefepime, aztreonam. You could use the carbapenems and the carboxypenicillins. That wasn't in this lecture either. Something like ticarcillin. Next. How does an organism develop resistance to vancomycin? So remember that resistance to vancomycin occurs from a change in the amino acid sequence from D-ala-D-ala to D-ala-D-lac. And the last one here, a patient is receiving an IV infusion of an antibiotic and the nurse calls you when he becomes flushed 15 minutes after the infusion started. What is the treatment for this patient? So this is, of course, our red man syndrome that we talked about from that vancomycin infusion. You're going to treat that by stopping the vancomycin, giving maybe an antihistamine, maybe diphenhydramine, and then you can restart it later on, but just at a slower infusion. All right, guys, that brings us to the end of our lecture. I hope you learned something. I'll see you next time.
Nurses ask for his autograph. He once won a staring contest against a man with no eyelids. He can clear arteries with a single look. He once diagnosed appendicitis and performed an appendectomy from his bedroom over the phone. He is the most exceptional doctor in the world.
I don't often give vancomycin, but when I do, I give it slowly. And I might pre-medicate the patient with antihistamines. Beware of red man syndrome, my friends.
Let's go over the warm-up review. First question, which antihypertensive drug is associated with each of the following side effects? So bradycardia and asthma exacerbation is going to be beta blockers. Reflex tachycardia would be any of the vasodilators, things like nitrates, the dihydropyridine calcium channel blockers, minoxidil, and hydralazine. Elevated antihistone antibodies should make you think about drug-induced lupus, and the antihypertensive that can cause that is hydralazine. And then hypercalcemia can be associated with hydrochlorothiazide. Remember, loops lose calcium, thiazides retain calcium. And the last question. In a study of 100 people, the results show an average of 500 with a standard deviation of 50. So calculate the 95% confidence interval. First, you have to remember the equation for confidence interval, which is the mean plus or minus z times the standard error of the mean. So let's start plugging in some numbers. They gave us the mean, or average, which was 500. Next, we need z. So for a 95% confidence interval, z equals 1.96, but we're going to use 2 to make the calculations easier. Then you need to figure out the standard error of the mean. The equation for this was the standard deviation divided by the square root of the sample size. So that's 50, the standard deviation, divided by the square root of 100, the sample size, or 50 divided by 10 equals 5. So the standard error of the mean is 5. So to plug in all our numbers, 500, the mean, plus or minus 2 times 5 equals 500 plus or minus 10. So the 95% confidence interval for this study is 490 to 510. Now let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on protein synthesis inhibitors. So let's jump in here. So protein synthesis inhibitors, so these antibiotics will work great on gram-negative infections in general. They specifically target smaller bacterial ribosomes. So the bacterial ribosome is a 70S ribosome. And these 70S ribosomes are composed of a 30S and a 50S subunit. And yes, the math does not add up here, but that's just the way it goes. The S is actually the measurement of the rate of sedimentation. So it doesn't relate to size exactly. So a 30S and a 50S subunit will make and combine a 70S bacterial ribosome. So these antibiotics will bind on one of these subunits, the 30S and the 50S. Now the human ribosome is an actual 80S ribosome. Its subunits are 40S and 60S, and again, yes, the math is not great here. So that's how these antibiotics can differentiate between a bacterial cell and a human cell, and that's good because we wouldn't want to take an antibiotic that would kill our own cells. Now we have a great mnemonic, bi at 30 cell, CCELL, at 50. Now this will help us to remember which antibiotics attack which subunit on the ribosome, either the 30 or the 50. So the 30S inhibitors include aminoglycosides and the tetracyclines. So that's the A and the T. Now for the CCELL at 50, the 50S inhibitors include chloramphenicol and clindamycin. The E stands for erythromycin, but also includes the rest of the macrolides, which we'll talk about here in a little bit. One of the L is going to be lincomycin, and then the last L is linezolid. Now, we will spend just a couple more seconds here talking about linezolid. It kind of is off on its own here. Look in the study guide. So the mechanism of action, it's going to bind to the 23S portion of the 50S ribosome. So yeah, there are subunits of subunits, and this interacts with the bacterial initiation complex and inhibits it. Now we use it mainly for MRSA, that methicillin-resistant Staph aureus, but we can also use it for VRE, vancomycin-resistant enterococci. And the vancomycin-resistant enterococci is very important here because it's killing people in the hospital. So what makes it this very novel medication is that it is an oral medication. So you can actually treat certain MRSA or even VRE infections on an outpatient basis. Now, before this medication, patients with significant but maybe very stable MRSA infections would have to stay inpatient in order to get their IV infusions, or they would have to come back once or twice a day to get their IV infusion. So this is a great medication because you can treat these difficult to treat infections with an outpatient oral medication, so a lot cheaper. Now, another characteristic of linezolid is that it seems to come up on questions is that linezolid can cause serotonin syndrome in patients also taking SSRIs. So make that connection as well. Let's move on to tetracycline. So tetracyclines include tetracycline, doxycycline, dimeclocycline, and minocycline. Now the name comes from the 4-ring structure found in each of these compounds. It binds to the 30S and prevents attachment of amino acyl tRNA. Tetracycline can actually bind to the 40S subunit on eukaryotes as well, but mammalian cells tend to be less vulnerable to the effects of the tetracyclines in general. Now these are bacteriostatic and they have limited CNS penetration. Doxycycline is fecally eliminated, and this can actually be pretty important because you can use this in patients with renal failure. Now, what are the clinical uses of the tetracyclines? So this is again in the study guide. There's a really nice mnemonic called vacuum the bedroom. So this will stand for Vibrio cholera, acne, chlamydia, ureaplasma urolithicum, mycoplasma pneumoniae, tularemia, H. pylori, Borrelia burgdorferi, and rickettsia. So that's going to be vacuum the bedroom. Now, you can't take the tetracyclines with milk or antacids or any iron-containing preparations because the divalent cations inhibit the absorption of this drug in the gut. So calcium, iron, magnesium, these are all divalent cations, and they will inhibit absorption of these antibiotics. Now, the tetracyclines have some unique toxicities. Now, the number one is GI distress, and this is doubly important because sometimes people will grab for antacids if they have some GI distress, and then their antibiotic won't be absorbed at all. Now, another more unique side effect is discoloration of teeth, especially in children. Patients can get kind of a nasty yellowish looking discoloration of their teeth. Also inhibits bone growth in children. So as you can tell with these two problems, you don't want to give this medication to children at all. Photosensitivity is also a minor problem. Remember the mnemonic SAT for photo. That stands for sulfonamides, amiodarone, and then tetracycline is the T. Very interestingly, with minocycline, it's unique. It has kind of a strange blue pigmentation of the skin after prolonged use. Now, when do you think you might use minocycline for prolonged use? Patients might take minocycline chronically for acne. And then the tetracyclines are contraindicated in pregnancy, so don't use them there. Let's move on to the aminoglycosides. So this includes drugs like gentamicin, neomycin, amikacin, tobramycin, streptomycin. So what is their mechanism of action? So it binds to the 30S ribosome again. It's bactericidal this time, and it inhibits the formation of the initiation complex and causes misreading of mRNA. Now, it does require oxygen, or O2, for uptake. Therefore, it is ineffective against anaerobes. Now, one memory tool you can use is amine O2 glycides. That they need that O2, so no good against those anaerobes again. Moving on to clinical use, we use these for severe gram-negative rod infections. It's nice because they also work synergistically with the beta-lactam antibiotic. So an example of this combination is maybe in a neonatal infection. If a neonate has E. coli pneumonia or E. coli sepsis, we often combine ampicillin and gentamicin, and that will help fight off that rather severe infection. Neomycin is sometimes used for bowel surgery. It helps with bowel infections. Toxicity, so this can cause nephrotoxicity. In the past, we thought that if you combined an aminoglycoside with cephalosporins, that the nephrotoxicity could be even worse, but the most recent data suggests that this isn't true, but you might still see that in other resources. Ototoxicity, this is especially prevalent when used with loop diuretics. And then it's also teratogenic. Now you can remember this as NOT. Nephrotoxicity, ototoxicity, teratogenicity. Don't get this confused with vancomycin, which also had that nephrotoxicity and ototoxicity, but it differed in that it can cause thrombophlebitis. In aminoglycosides, that T is for teratogenic. All right, so now let's move on to macrolides. So these drugs are very commonly used. So this includes erythromycin, azithromycin, clarithromycin. So what's the mechanism here? Well, it inhibits protein synthesis by blocking translocation. So it's going to bind to the 23S rRNA of that 50S ribosomal subunit. So this is actually pretty similar to linezolid. We just talked about that a minute ago. So it's binding to that 23S rRNA, and that's just sort of a little subunit of the subunit 50S ribosomal. So this is a bacteriostatic drug. Now for its clinical use, we're going to look in the study guide again and write this down. I try to think of it as pus, P-U-S. So macrolides are treating pus. The P stands for pneumonia, especially the atypical pneumonias. And what causes your atypical pneumonias? Remember, it's mycoplasma, chlamydophila, legionella. And then for the U, think of URI, upper respiratory tract infections. Now, what type of bacteria are we thinking about here? Strep pyogenes, H. influenza. Now, it used to cover strep pneumo a little bit better, but there is growing resistance there. It can kill staph, but not generally MRSA. You can also get Legionella, Bordetella pertussis as well. And then the S in pus is STD, so sexually transmitted infections or diseases. So think of chlamydia, think of gonorrhea. Next, we're moving on to toxicity. So the most important side effect is prolonged QT interval. So you have to watch out for your patients who already have a prolonged QT interval. Make sure you avoid the macrolides because you can potentially prolong that further and then maybe cause an arrhythmia. Now, besides this, the macrolides can cause GI discomfort. Rarely acute cholestatic hepatitis, which only happens with one type of macrolide, and that's erythromycin estolate. You can also have some rare cases of eosinophilia. Now, there are some important drug interactions. The macrolides can increase serum concentrations of theophylline and oral anticoagulants like warfarin. Now, one nice thing is that most of the macrolides are safe in pregnancy. Erythromycin, azithromycin, probably the safest. So when you have an upper respiratory tract infection in pregnant women, we will often use a macrolide, especially azithromycin. Now, for resistance, you do get some methylation of that 23S rRNA binding site, and that helps prevent the binding and inhibition of the antibiotic. Chloramphenicol. Chloramphenicol, a very interesting drug. So its mechanism of action is that it inhibits the 50S peptidyltransferase activity, and it is bacteriostatic. Now, this medication isn't used that often anymore. It does have some harmful side effects, and we have other medications that we use for the type of things that it's going to potentially treat. So what does it treat? Well, it treats meningitis, so it will be effective in H. influenza, Neisseria meningitis, and strep pneumo. Again, we don't use it very often because of its toxicities. Now, the toxicities include anemia, and this seems to be dose dependent. So the more drug you give, the more anemia you're going to get. Aplastic anemia can occur as well. Now, one very unique adverse reaction is gray baby syndrome. So what's this? Premature infants can lack enough liver UDP glucuronal transferase. Now, this enzyme is very important in metabolizing chloramphenicol. So if you give a premature newborn chloramphenicol, you can produce a buildup of toxic metabolites. Now, the toxic levels will occur about 2 to 9 days after birth or after giving the drug, and the symptoms include vomiting, ashen gray color of the skin, poor muscle tone, cyanosis, and cardiovascular collapse. Not very good stuff. Now, to treat this, you stop the chloramphenicol, exchange transfusion can be used, or sometimes phenobarbital can be added because it induces UDP glucuronal transferase, but we don't really use this drug anymore, so you'll probably never see it in real life. Moving on to clindamycin. So clindamycin has a mechanism that it blocks peptide bond formation with the 50S ribosomal subunit. It is bacteriostatic. It's one of the C's in cell. So for its clinical use, it's one of the few medications that we use for anaerobic infections, but it can also be used for MRSA infections, protozoal infections, and is even used topically for treating acne. So it's been used for Bacteroides fragilis and Clostridium perfringens as well. But generally speaking, when you have anaerobic infections, you want to think about clindamycin. Now, when we talk about serious MRSA infections, what drug do we think about first? We usually think about vancomycin. But when we see skin abscesses that are usually caused by MRSA, oral clindamycin is still a very good choice there. Not every skin abscess is going to need IV vancomycin. Now, it's nice to have a medication like clindamycin in that outpatient setting. Now, it does have some significant toxicity. You will see questions on this. Clindamycin is often indicated when patients contract pseudomembranous colitis. Now, what's the bacteria that overgrows in that condition? Remember, it's C. diff, C. difficile. So remember that Clostridium difficile is the overgrowing bacteria in that pseudomembranous colitis. Now, other antibiotics can cause pseudomembranous colitis, but clindamycin is probably the most commonly implicated one, especially on test questions. So now let's move on to the streptogramins, a not very often used group of meds here. Quinupristin and dalfopristin are used together. These drugs are synthesized by the bacteria Streptomyces virginii. They act by binding the 23S portion of the 50S ribosome. Uses, you're going to use this for MRSA, VRE, staph, and strep skin infections as well. Side effects include hepatotoxicity, that pseudomembranous colitis that we just talked about, arthralgias, myalgias, which significantly limit their use. And it's also going to inhibit cytochrome P450. Now for the glycocyclines, one newer antibiotic class, the glycocyclines. I think someone dared a drug researcher to see how many L's, C's, and Y's they could put into one word. The one drug worth remembering here is tigecycline. So this binds to the 30S and is bacteriostatic. So this is broad spectrum drug here. It can be used for anaerobic, gram-negative, gram-positive. So we use this for multi-drug resistant MRSA, VRE infections. Side effects include nausea and vomiting. All right, so before we get to the end of session quiz, let's hit the high yield stuff again in a Lewis Notes. All right, everyone, before we get to that end of session quiz, let's do another Lewis Notes, and we're looking at a few of our antibiotics here again. This is by no means a comprehensive list of what these things are most known for, but it is going to give us some of the buzzwords that if you see these on your test, you can immediately think about these drugs. So let's get through here. We're talking about linazolid, tetracycline, aminoglycosides, macrolides, chloramphenicol, clindamycin. So you might want to write this down yourself. So let's start up here at the top here with ototoxicity. There are several drugs that do ototoxicity, but the one that's going to match here is going to be with aminoglycosides. Remember, it can also do some nephrotoxicity, and also it's a teratogen. Next, we have pseudomembranous colitis. Now, this one's probably the most controversial one out of all this list. We're going to put this next to clindamycin. Just about any antibiotic can cause pseudomembranous colitis, but clindamycin is sort of the one that gets beat up the most with that one. Next, we have prolonged QT, so that interval can be prolonged in macrolides, so be careful about that with some of your cardiac patients. Next, we have gray baby syndrome. So we almost never use chloramphenicol, but I tell you what, test makers love to talk about gray baby syndrome, which I've never seen in my life. Photosensitivity, a relatively common side effect, but especially common in our tetracycline users here. MRSA VRE coverage. So this one is going to go with linazolid. Remember that linazolid is so great because it's an oral medication. All right, so next we have anaerobic coverage. This one's going to go over here by clindamycin. So clindamycin can be good for that. Also good for MRSA skin infections. Next we have discolored teeth. Specifically in children, this is going to be with tetracycline again. Tetracycline has those very interesting side effects. And then atypical pneumonia coverage, think of your macrolides. So macrolides we're going to use for atypical pneumonia. So a lot of buzzwords here. If you can kind of remember all these, that'll give you a leg up on your test.
First question, what are the side effects of the aminoglycosides? Remember that mnemonic, not NOT. So that's going to stand for nephrotoxicity, ototoxicity, and teratogenic. Next. What drugs have photosensitivity reactions? Remember our mnemonic was SAT for a photo. So sulfonamides, amiodarone, and what we talked about here, tetracyclines. Next, what causes gray baby syndrome, gray man syndrome, and red man syndrome? So gray baby syndrome is associated with chloramphenicol. Gray man syndrome is amiodarone, and again, that's an antiarrhythmic drug. And then red man syndrome is from vancomycin. Next, what are the clinical uses for macrolides? Remember our mnemonic pus. So pneumonia, especially our atypical pneumonias like mycoplasma, chlamydophila, legionella, upper respiratory tract infections, and then sexually transmitted diseases for the S. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, which areas of the hypothalamus regulate the autonomic nervous system? So the anterior hypothalamus controls the parasympathetic nervous system, and the posterior hypothalamus controls the sympathetic nervous system. And the last question, an investigative test uses a lab marker SCSQ to identify early small and squamous cell lung cancers. In a population of 100 smokers, 20 test positive. Of the 20 who test positive, 5 actually have either of the 2 lung cancers. So of those who do not test positive, it's determined that 5 have either of the 2 cancers. So what are the sensitivity, specificity, positive predictive value, and negative predictive value of this study? So here's how you're going to set up this problem. A is 5, B is 15, C is 5, and D is 75. So for sensitivity, you plug your numbers into the equation A over A plus C, and you get 0.5. For specificity, the equation is D over D plus B, and you get 0.83. For positive predictive value, the equation is A over A plus B, and you get 0.25. And finally, for negative predictive value, the equation is D over C plus D, and you get 0.94. Now let's move on to the lecture.
Hey guys, Dr. Carmichael here, and welcome to our Step 1 video on the other antibiotics. Once again, we have a group of antibiotics that don't really fit nicely into 1 or 2 categories. The common thread on the first drugs is that they can treat UTIs, but later we'll look at drugs like metronidazole and the polymyxins, and then close to the end we'll cover some specific situations where antibiotic prophylaxis is needed. The most commonly used sulfonamides are sulfamethoxazole, or SMX, which is easily the most commonly used, and sulfadiazine. Let's go over the mechanism of action of sulfonamides. Simply put, they are folic acid inhibitors. So that's how I like to think about this. Bacteria have no way of absorbing the folic acid from the environment, so they have to produce it internally. We humans can actually absorb folic acid from the environment. That's why we have pregnant women take a bunch of folic acid, because they can use it. The goal of these antibiotics is to prevent the production of folic acid in these bacteria and therefore deprive them of a vital component of their cell synthesis. Sulfonamides are competitive inhibitors of the enzyme dihydropteroate synthetase, which is a critical enzyme in folate synthesis. Sulfonamides can cover some gram-positives and gram-negatives. It can cover nocardia, chlamydia, and is used frequently for UTIs. Other clinical uses include skin infections as well. Most of the time, sulfonamides are used in combination with trimethoprim. By far, the most common combination is sulfamethoxazole combined with trimethoprim, TMP-SMX. The toxicities of the sulfonamides most commonly is a hypersensitivity reaction. There are quite a few people in the world with sulfa allergies. Hemolysis, especially if the patient is G6PD deficient. Nephrotoxicity, you can get some with tubular interstitial nephritis. Kernicterus can occur in infants, so you don't want to give this medication to infants or mothers who are about to deliver. It can displace other drugs from albumin, especially warfarin. You can get Stevens-Johnson syndrome, and you can get some photosensitivity. For resistance, you can get altered enzymes, so the bacterial dihydropteroate synthetase can be altered. You can get decreased uptake. You can get increased PABA synthesis. So, I mentioned before that many people have a sulfa allergy, but this doesn't just include sulfonamides. There are other drugs that are considered sulfa drugs, and we have a mnemonic to help us remember them. The mnemonic is, sulfa pills frequently cause terrible allergy symptoms. Sulfasalazine, probenecid, furosemide, celecoxib, thiazides, and TMP-SMX, acetazolamide, and sulfonylureas. In that list of reactions seen with sulfonamides, we also mentioned Stevens-Johnson syndrome. Let's review that one again. What drugs cause Stevens-Johnson syndrome? The mnemonic is, Steve Jobs made Apple PCs. Steve Jobs is supposed to make you think Steven Johnson, and then Apple PC will stand for allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfonamides. We just mentioned that we often use trimethoprim in combination with our sulfa drugs. So what is the mechanism of trimethoprim? It inhibits bacterial dihydrofolate reductase, so it's further down in the pathway of folic acid synthesis. The sulfonamides are inhibiting it at an earlier step. Remember, the sulfonamides are inhibiting dihydropteroate synthetase, and trimethoprim is inhibiting dihydrofolate reductase. So when we like to use the TMP-SMX, we are hitting folate synthesis at two different locations. You almost never see trimethoprim used alone. There's another medication that inhibits dihydrofolate reductase. That's going to be methotrexate, and we use that a lot for rheumatological disorders. What are the clinical uses of trimethoprim sulfamethoxazole? It causes sequential block of folate synthesis, so you can use it for UTIs, Shigella infections, Salmonella infections, and sometimes we use it in MRSA skin infections. Patients who have frequent recurring UTIs may take TMP-SMX regularly to prevent UTIs. In our AIDS patients, we use this prophylactically and as treatment for pneumocystis jirovecii pneumonia. When do we start using this as a prophylactic medication? It's when the CD4 count gets below 200. The toxicity in trimethoprim can lead to diseases where you get deficiency in folic acid, so megaloblastic anemia, leukopenia, and granulocytopenia. But the nice thing is you can reverse this just by taking a folic acid supplement. Another commonly used antibiotic in UTIs is nitrofurantoin. It's bactericidal in urine. Nitrofurantoin is reduced by bacterial proteins to a reactive intermediate that inactivates bacterial ribosomes. It has to be in the presence of bacteria in order for it to become effective. This medication is really only used to treat UTIs and generally mild UTIs. You don't want to use this for pyelonephritis or suspected pyelonephritis, and it's usually only good for treating bacteria like E. coli or Staph saprophyticus. Now that's great because those are very commonly found in UTIs, but it does not cover Proteus, which is another very common UTI-causing bacteria. The toxicity of nitrofurantoin is rare, but you can have nausea, headaches, or diarrhea. Another reason to use this medication is that it is safe in pregnancy. We're going to move on to the fluoroquinolones. levofloxacin, ciprofloxacin, norfloxacin, ofloxacin, moxifloxacin, gadafloxacin, and nalidixic acid. Though it is not overly important, nalidixic acid is actually just a plain quinolone, not a fluoroquinolone. The mechanism of action of fluoroquinolones is that they inhibit DNA gyrase. It's important to know that that's topoisomerase 2. Remember, topoisomerase 2 is sort of the janitor of DNA. It does some of the nicking and removing. It doesn't actually change your DNA sequence per se, or what's actually coded. It just may help tidy things up. You don't want to take these with antacids or supplements that include calcium, iron, or magnesium, as it can inhibit the absorption. So for clinical use, we're going to use these for gram-negative infections, gram-negative rods, urinary tract infections, and GI tract infections. Some of these medications can cover Pseudomonas. There are varying amounts of gram-positive coverage. The first generation of drugs that we don't use anymore didn't cover gram-positives as well, but the second and third and fourth generations have much better gram-positive coverage, especially against strep pneumonia. Levofloxacin, third generation, and moxifloxacin, fourth generation, are great for strep pneumonia infections and are often used for community-acquired pneumonias or sinusitis. The toxicity of these is they have some pretty unique ones. GI upset is very common for most antibiotics, but it is contraindicated in pregnancy and children because of damage to cartilage, especially articular cartilage. One way to remember is that fluoroquinolones are bad for cartilage and your bones. So just remember that articular cartilage can be damaged in children. You can also get tendinitis or even tendon rupture in adults. So be aware that if you have an adult on fluoroquinolones and their Achilles tendon starts hurting, you probably want to tell them, 1, get off the medication, and 2, don't go for a long run. Fluoroquinolones can also prolong the QT interval. You can use fluoroquinolones in children in one situation, and that's going to be cystic fibrosis. So cystic fibrosis patients get a lot of lung infections, especially Pseudomonas infections. So you can use medications like ciprofloxacin on a long-term basis, but you need to pay special attention to their cartilage and make sure they're not having any joint problems. The resistance to fluoroquinolones is chromosome-encoded mutation of DNA gyrase. So if the enzyme gets changed, you have less effectiveness. Okay, so that's going to finish off our UTI drugs. Let's cover some more antibiotics that don't necessarily fit into a larger category. Metronidazole is an antibiotic, but we also use it to treat protozoal infections. So how does it work? It gets absorbed by microorganisms and then it forms toxic free radicals that damage the DNA. And what specific organisms are we talking about? There's a great mnemonic that's been around for ages. It's get gap on the metro. Metro is metronidazole, and get gap stands for Giardia lamblia, Entamoeba histolytica, Trichomonas, Gardnerella vaginalis, which is a bacteria, not a protozoa, anaerobic bacteria, which includes things like Clostridium species such as C. diff, C. perfringens, which causes gangrene, C. tetani, which causes tetanus, and also Bacteroides fragilis, so anaerobes think about Clostridium and Bacteroides. And then the P in GAP is for pylori, H. pylori. Metronidazole is one part of the triple therapy or quadruple therapy that can treat H. pylori. It's not first line, but it can still be used. So that's the story for get gap on the metro. The first 3 are protozoal organisms, and the last 3 are bacteria. Then, the other big thing to know about metronidazole is that it can cause a disulfiram-like reaction with alcohol. So what is a disulfiram-like reaction? We covered this in a couple places through the course because there are several drugs that might do this, but let's just review. Disulfiram is a drug that inhibits acetaldehyde dehydrogenase, so it prevents ethanol from becoming fully metabolized. When that happens, you get an accumulation of acetaldehyde, and that causes flushing, sweating, nausea, headache, and sometimes hypotension. And metronidazole can cause very much the same thing. So it's important to warn patients that this drug will cause that reaction before they start taking it. Tell them they shouldn't drink any alcohol while they are on the metronidazole, or it will make them very, very sick. Polymyxins act like cationic detergents. They attach to and disrupt bacterial cell membranes. They also inactivate endotoxin. For clinical uses, they are used for resistant gram-negative infections. For toxicity, they are neurotoxic and can cause acute renal tubular necrosis. And because of this, polymyxin are almost always used topically. So we see this used in many topical antibiotics like over-the-counter Neosporin. Briefly, we're going to talk about non-surgical antimicrobial prophylaxis. We talked about these a lot already. There are certain infections that if you get exposed to them or you have the potential to be exposed to them, you can take a prophylactic antibiotic. First, if you're exposed to a patient with meningococcal meningitis, ciprofloxacin is going to be your drug of choice, but you can also use rifampin or ceftriaxone. What about H. influenzae meningitis? Do we use Cipro there? No, we use rifampin instead. What if you want to prophylax for gonorrhea? When would you want to prophylax for gonorrhea? This might occur when the patient has been sexually assaulted and you want to ensure that they do not acquire gonorrhea, so ceftriaxone is what we use here. Syphilis prophylaxis, benzathine penicillin G. History of recurrent UTIs, so here you actually have a lot of options. You can use the trimethoprim sulfamethoxazole for long term. You can use nitrofurantoin long term. You can also use amoxicillin long term or cephalexin. Prophylaxis for pneumocystis jirovecii. This causes pneumonia in AIDS patients. So for prophylaxis, we use TMP-SMX most of the time. When do we start prophylacting for pneumocystis jirovecii pneumonia in an AIDS patient? When the CD4 count falls below 200. And what happens if the patient is sulfa allergic and can't take the TMP-SMX? So you actually have two other options. First, you can use aerosolized pentamidine. The other option is dapsone. So there are three prophylactic options here: TMP-SMX, pentamidine, or dapsone. Next, patients with mechanical heart valves or damaged endothelium of the heart can acquire endocarditis by having bacteria entering the bloodstream through dental procedures. They can take penicillin, or they can take one of the aminopenicillins like amoxicillin, or they can take cephalexin, which is the first generation cephalosporin. If there is a penicillin allergy, then you would use clindamycin or maybe azithromycin. And what was one of the major bacteria implicated with these? Viridans strep. Pregnant women with GBS. Remember, this doesn't adversely affect the mother, but it can lead to problems in the newborn, so we use ampicillin during labor to prevent transmission to baby. Prevention of gonococcal or chlamydial conjunctivitis in the newborn, we use erythromycin ointment in the eyes of all newborns. There are a list of antibiotics you should not use in pregnancy, and these are potentially high yield for STEP, and some of them we are learning about today, but others we need to review as well. Clarithromycin is embryotoxic. Sulfonamides cause kernicterus and only if taken close to delivery. Aminoglycosides cause ototoxicity. Fluoroquinolones can cause cartilage damage. Metronidazole causes mutagenesis only in the first trimester. Tetracyclines cause discolored teeth and inhibit bone growth. Ribavirin is teratogenic. Griseofulvin is teratogenic. And chloramphenicol causes a gray baby. Which is used for prophylaxis for the following infections? Gonorrhea is ceftriaxone. Syphilis is penicillin G. Recurrent UTIs can be TMP-SMX, nitrofurantoin, or cephalexin. Pneumocystis jirovecii pneumonia, or PCP, is TMP-SMX. Exposure to H-flu type B meningitis is rifampin. Endocarditis prevention in a patient with a mechanical heart valve. Remember that there are very specific criteria for who really need antibiotic prophylaxis for the endocarditis, but if indicated, we usually use amoxicillin, ampicillin, and if the patient is allergic to penicillin, we would use clindamycin or azithromycin. What are the major side effects of IV polymyxins? Neurotoxicity and nephrotoxicity. When should trimethoprim sulfamethoxazole be started for prophylaxis against pneumocystis jirovecii patients with HIV? That's when the CD4 count falls below 200. What is the mechanism of action of the following antibiotics? Sulfamethoxazole inhibits dihydropteroate synthetase. Trimethoprim inhibits dihydrofolate reductase. Levofloxacin inhibits DNA gyrase or the topoisomerase II. Nitrofurantoin inhibits bacterial ribosomes. Metronidazole forms toxic free radicals that damage the DNA. And polymyxin B acts like cationic detergent. cationic, like cations and anions. That's it for this, guys. We'll see you at the next one.
It's time for another warm-up. Let's get going. In a randomized, placebo-controlled study of a new blood pressure medication, members of the study group received their supply of pills at a monthly clinic visit. The blood pressure is checked, and the clinic nurses are available to answer questions and instruct the patients on the importance of controlling blood pressure through diet, exercise, and weight loss. Members of the control group receive their supply of placebo pills in the mail each month. After 6 months, the study group's mean systolic blood pressure has decreased 11 points from baseline, compared to a 2-point decrease in the control group. Which type of bias may have contributed to the difference in the outcomes between these two groups? So this is what we call a procedure bias. All that counseling, even though it may seem minor and basic, all that counseling may have encouraged the study group to eat better or exercise more or even just take their study medications more regularly than the control group. So if you wanted to redesign the study to eliminate the procedure bias, you would need to bring in the control group for the monthly blood pressure check and nurse counseling as well, so that both groups are treated exactly the same. Next question, what is pulsus paradoxus and what are the causes? So pulsus paradoxus is when the systolic blood pressure drops by more than 10 millimeters of mercury with inspiration. And that's going to be caused by things like hyperinflation of the lungs, things like asthma, COPD. Croup can potentially do this as well. It's also caused by cardiac tamponade. All right, that's it for the warm-up. Let's get to that lecture now.
In the next few videos, we're going to review microbiology by organ systems, more of a clinical approach. Now, a lot of this material is reviewed from previous videos, but we're going to be approaching it from a different perspective. Let's start by talking about the normal flora. A lot of our body is covered by bacteria all the time, and most of these bacteria are benign or even beneficial. But some of these normal flora bacteria can cause problems if they move to a different part of the body. For example, the dominant bacteria on the skin is Staph epidermidis, which is sometimes called Staph epi or coagulase negative staph, or coag negative staph. And Staph epi can be beneficial on the skin. It helps to prevent the growth of yeast, for example. But if you break the skin with an IV or a central line or by shooting IV drugs, Staph epi can then get into the bloodstream, and that leads to bacteremia or endocarditis. In the nose, Staph epidermidis and Staph aureus are commonly found, so the nares are an important source for MRSA colonization. The oral cavity is full of bacteria, and that's why human bite wounds are polymicrobial. The mouth can contain anaerobes and staph and strep, as well as other species. Now, one strep species you should remember in particular is Streptococcus mutans, which is a viridans group strep. Strep mutans is found in dental plaque and dental caries, or cavities. So in patients with prosthetic heart valves, strep mutans from the mouth can seed the heart after dental procedures and cause some endocarditis. And that's why certain patients need prophylaxis when they have dental procedures. At the other end of the GI tract is the colon, which contains lots of different bacterial species. But the most common is probably Bacteroides fragilis, which is an anaerobe. This is actually more prominent than even E. coli, but E. coli can get into the urinary tract, which is nearby, and that leads to urinary tract infections. We'll cover that in another video. The most common bacteria in the vagina is Lactobacillus. Now, Lactobacillus converts glycogen to lactic acid, which makes the vaginal pH acidic in the 4 to 4.5 range. And that lower pH helps to inhibit the growth of pathogens. The vaginal flora also includes E. coli, anaerobes, and staph and strep. Group B strep, or Streptococcus agalactiae, is important clinically when it colonizes the vagina of a pregnant woman because it can be transmitted vertically to the baby during labor and delivery, and that leads to neonatal sepsis, meningitis, or pneumonia. So we screen for group B strep during pregnancy, and if the mother's group B strep positive, we give penicillin during labor to prevent transmission to the infant. Let's talk about pneumonia and the bacteria that commonly cause pneumonia in different age groups, starting with neonates. By definition, a neonate is up to 28 days old. Now, during the neonatal period, you worry about vertical transmission of bacteria from the mother to the infant. So the most common cause of pneumonia in neonates is group B strep. Then you also worry about E. coli. And less commonly, you'd worry about chlamydia trachomatis and herpes simplex virus. So these both cause genital infections in the mother, and if they're transmitted to the baby during delivery, that can lead to pneumonia. But because chlamydia has this long incubation period, You might not see any clinical evidence of infection until much later, 4 weeks, 8 weeks, even up to 12 weeks later. But the two most important causes of neonatal pneumonia are Group B strep and E. coli. Now, beyond the neonatal period in children, the most common cause of pneumonia is viruses like RSV or respiratory syncytial virus, especially in younger children. The most common bacterial cause is strep pneumoniae. And in older children, you also have to think about atypicals like Mycoplasma pneumoniae and Chlamydophila pneumoniae. Now, in adults, the most common cause of pneumonia is strep pneumoniae again. Other bacterial causes are Haemophilus influenza, and again, Mycoplasma and Chlamydophila. Now, Mycoplasma is very, very common in young adults. And then, especially in older adults, you can also see some viral causes sneaking in, like influenza virus. And then in elderly patients, strep pneumoniae is still the most common cause, followed by H. flu and influenza virus. And then you also have to worry about Staph aureus and anaerobes and gram-negative rods. You can also see pneumonia from specific pathogens in very specific patient populations. Now, some of these are pretty uncommon, but the clinical history is a big giveaway for you on your board. Pneumonia in an alcoholic patient should make you think of Klebsiella pneumoniae, which can cause a thick, bloody sputum that's described as currant jelly sputum. Not that I've ever had jelly made out of currants, or anything made out of currants. I'm not even sure what currants look like. Next is pneumonia in a patient with decreased level of consciousness. So that's worrisome for aspiration pneumonia, which is a big risk factor for anaerobes. Patients with cystic fibrosis are at increased risk for Pseudomonas. Pneumonia in a patient with HIV and a CD4 count less than 200 should make you think of Pneumocystis jirovecii. Pneumonia post-influenza infection. Strep pneumo is the most common cause, but also no Staph aureus for this one because Staph aureus can cause a severe post-influenza pneumonia that's often fatal. Pneumonia acquired from a patio cooling water mister is going to be Legionella pneumophila. So whenever there's a water source, think about Legionella. Next one, travel to southwestern U.S. is going to be Coccidioides immitis, which is a fungus. Exposure to bird or bat droppings in the Ohio and Mississippi river valleys is another fungus, Histoplasma capsulatum. And then finally, pneumonia in a patient with a parrot, think about Chlamydophila psittaci. That's associated with birds. Meningitis is inflammation of the meninges, most commonly due to infection. And like with pneumonia, the most likely cause of meningitis varies by the age of the patient. In neonates, you worry about Group B strep and E. coli, just like with pneumonia, but then also, less commonly, Listeria monocytogenes. In infants and children, you start to see some of the more common causes of meningitis, like strep pneumoniae and Neisseria meningitidis. So strep pneumo is the most common cause of meningitis overall in all types of patients. Haemophilus influenza type B used to be a major cause of meningitis in children, but that number has declined dramatically because of immunization. And you can also see viral meningitis, which is most commonly caused by enteroviruses such as Coxsackie virus. Now in adults, strep pneumoniae is by far the most common cause of meningitis, followed by Neisseria meningitidis again. Now meningococcal meningitis tends to affect healthy young patients, teenagers and young adults. And you'll still see some enteroviruses causing viral meningitis in adults. And then in elderly patients over 60, strep pneumoniae is still the most common cause, but then that's followed by Listeria monocytogenes, which we saw in neonates, and you also worry about gram-negative rods like E. coli. Let's go over some other clinical clues that they might give you. What organism should be considered as the cause of meningitis in each of the following scenarios? So the first one is meningitis in an unvaccinated child. So if they tell you the kid's unvaccinated, you should immediately think of Haemophilus influenza type B. An outbreak of meningitis in a dormitory is classic for Neisseria meningitidis. College dorms and military barracks are the classic locations for meningococcal meningitis outbreaks because you have lots of young adults living in close quarters. Meningitis with a petechial rash is Neisseria meningitidis again. Meningitis in an HIV patient should make you think of Cryptococcus neoformans, which you could test for with an India ink stain on the CSF. And finally, red cells in the CSF plus temporal lobe involvement on MRI. Now this one's a type of encephalitis, not meningitis, but if you see red cells in the CSF and temporal lobe involvement, think about HSV encephalitis. Now how does meningitis present clinically? Well, you should think about meningitis when you see a patient with fever, severe headache, nuchal rigidity or neck stiffness, photophobia, or altered mental status. To confirm the diagnosis, you need to do a lumbar puncture and analyze the CSF. So let's talk about the CSF findings with meningitis. Now, this is a 4-star topic, but it's really not that hard, so it should be a pretty easy question for you. With bacterial meningitis, the opening pressure will be elevated. The white cell count in the CSF will be elevated, often markedly elevated, with a predominance of neutrophils. CSF protein will be high and glucose will be low. And gram stain will be positive for bacteria in about 70 to 80% of cases. But a negative gram stain does not rule out bacterial meningitis. For the most part, fungal meningitis and TB meningitis will look pretty similar to bacterial meningitis. Opening pressure is elevated, CSF white count will be elevated, although maybe not as much. Proteins elevated, glucose is decreased. The big difference is that with fungal or TB meningitis, the white cells in the CSF are predominantly lymphocytes rather than neutrophils. And the gram stain will generally be negative. So that's how you can distinguish fungal and TB meningitis from bacterial meningitis. Then what do you see with viral meningitis? Well, you might not see anything. The CSF could be completely normal. Or you might have an elevated opening pressure, an elevated white cell count with a predominance of lymphocytes, and an elevated protein. But the glucose is usually normal, and the gram stain is negative. Sometimes, instead of giving you the full CSF results, they'll give you a patient with meningitis symptoms, fever, headache, neck stiffness, and then they'll show you a gram stain, and they'll ask you to choose the most likely organism. So if they show you gram-positive diplococci, you should think about strep pneumoniae. Gram-negative diplococci would be Neisseria meningitidis. Gram-negative coccobacilli should make you think of Haemophilus influenza. And gram-positive rods is Listeria monocytogenes, especially in an elderly patient or a neonate. Optimal treatment of meningitis really depends on the organism, but for empiric treatment, you're going to start with broad-spectrum antibiotics like ceftriaxone plus vancomycin plus or minus ampicillin, depending on whether or not you suspect Listeria. Let's talk about bioterrorism. If you're taking Comlex Level 1, you may see questions on bioterrorism where you're expected to recognize the bioterrorism agent or the clinical presentation, or possibly to know the precautions to take when there's a bioterrorism attack. Now, I've not heard of this turning up on USMLE yet, but it does get tested on Comlex. Bioterrorism just means the use of biological agents as a weapon, usually on a civilian population. Now, the CDC has identified about 30 potential pathogens that could be used in bioterrorism attacks. And I want to briefly review two big ones: Bacillus anthracis, which causes anthrax, and smallpox. Now, in addition to those, you may want to go back and refresh your memory on Yersinia pestis, which causes the plague, Clostridium botulinum, which causes botulism, Francisella tularensis, which causes tularemia, and the filoviruses like Ebola virus and Marburg virus. These are the CDC's highest risk bioterrorism pathogens because they cause high mortality and they're easy to grow in large quantities and they're pretty resistant to destruction. Plus, there's a certain psychological component when you think about the panic that would be caused by a widespread outbreak of plague or Ebola or smallpox. So let's review a few details about anthrax and smallpox. Anthrax is caused by Bacillus anthracis, which is a gram-positive rod, and it produces a couple of different toxins, edema factor and lethal factor. It also forms spores, which makes it very hard to kill and eradicate, and that makes it easy to transmit. Now, anthrax causes a couple of different syndromes. If the spores get on your skin, you can develop cutaneous anthrax with a necrotic ulcer that turns into a black eschar surrounded by erythema and edema. But if you inhale the spores, you could develop pulmonary anthrax or inhalation anthrax, which spreads to the lymph nodes in the mediastinum. So widening of the mediastinum in a patient with prominent pulmonary symptoms like cough and fever could suggest pulmonary anthrax. And then those infected lymph nodes become necrotic and hemorrhagic, and the bacteria become bloodborne, and the patient develops shock and dies fairly quickly. It's really nasty. And anthrax can also cause hemorrhagic meningitis. In terms of bioterrorism, if you have a patient who's been exposed to anthrax spores, first you want to remove their clothes and seal them in a plastic bag. The clothes, not the patient. You should wash the patient's skin carefully with soap and water, but not that alcohol-based rub because that's not going to kill the spores. And then post-exposure prophylaxis includes either ciprofloxacin or doxycycline. And there's also an anthrax vaccine that's recommended as well. There's also a drug called raxibacumab that neutralizes the toxins. And that's only recommended when other prophylactic agents aren't available. Smallpox is a disease that's been eradicated, but there's concern that it could be weaponized. It's caused by the variola virus, one of the pox viruses, and it's transmitted by respiratory droplets or by contact with contaminated objects like clothing. It has about a 2-week incubation period, and then the victim develops a rash around the mouth that kind of spreads to the face and then the trunk and the extremities. And the rash turns into these characteristic vesicles and pustules which can basically cover the entire body. The procedures for managing a smallpox exposure are much less well defined, but again, you need to remove the clothes, wash carefully, and then contact the CDC and the health department if you want to consider giving the smallpox vaccine. Now it's time for the end of session quiz. So pause the video, work through those questions, then we'll go over them together. First question, what 2 organisms are important causes of both pneumonia and meningitis in neonates? We mentioned group B strep and E. coli. Next, a 32-year-old man comes to the hospital after the abrupt onset of fever, chills, and a productive cough. An x-ray of the chest is consistent with pneumonia. Gram stain of the sputum shows gram-positive diplococci. So what's the most likely causal organism? Well, gram-positive diplococci should immediately make you think of Streptococcus pneumoniae, which remember is one of the most common causes of both pneumonia and meningitis. And the last one, what CSF findings help to distinguish bacterial meningitis from viral meningitis? Well, with bacterial meningitis, you see increased opening pressure, increased protein, low glucose, and the white cells in the CSF are mostly neutrophils. With viral meningitis, the opening pressure and protein can be increased, but usually not as much as they are with bacterial meningitis. Glucose is usually normal. The white count's still going to be increased, but the cells are primarily lymphocytes. That's it for now. I'll see you next time.
I'm sorry, were you looking for someone?
I was told I could get help from someone called Houseless.
Why would you want to talk to that idiot? He has no idea what he's talking about. Fine, I'll get him for you. You were looking for me? Sorry about my friend, he can be a real jerk.
You're Houseless, the so-called Dr. Genius. I have a patient who came in with a non-productive cough and night sweats. We assume Mycobacterium tuberculosis, but when the PPD was non-reactive and the sputum came back negative with AFB, I just assumed...
You and your intern friend stumped, huh? Why am I not surprised? Have you tried a chest x-ray? If you did, you would find that what your patient has is pneumocystis jirovecii pneumonia. You need to start treatment. Combination of sulfamethoxazole and trimethoprim.
How did you know that?
Unlike you, this ain't my first tango. Well, I guess it's back to my magazine. Lindsay, how you keep us continually entertained.
It's time for another warm-up. Let's get going. What are the common side effects of beta blockers? Which patient population should use caution when taking beta blockers? All right, so the common side effects are exacerbations of asthma, especially with the non-selective beta blockers. That can raise also the blood glucose. It can mask the symptoms of hypoglycemia, which is a big deal. Bradycardia, AV block, very, very common. And also think about CHF. The negative inotropic is going to depress that myocardial contractility. So you're going to use these again with caution when patients who have asthma, patients who have diabetes, and patients who have CHF. Next, what immunopathology is associated with each of the following statements? So first we have the anti-mitochondrial antibodies. Think about primary biliary cirrhosis. Antiplatelet antibodies. Think of idiopathic immune thrombocytopenic purpura, or ITP. Newborn with chronic diarrhea, failure to thrive, and chronic candidiasis. Think of SCID, so severe combined immunodeficiency. Next, we have child with eczema. So we have coarse facial features and cold abscesses. Think of the hyperimmunoglobulin E syndrome, also referred to as Job syndrome. And then we have child with partial albinism, peripheral neuropathy, and recurrent infections. That's the Chidiac-Higashi disease. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here. We're going to be going over Step 1, Micro 17. In this video, we're going to review some infections of the genitourinary tract. And it's a time-honored tradition, pretty much every lecture on sexually transmitted infections ever, I'm going to show you some pictures of disgusting genital lesions, but just a few, because unlike your high school health teacher, I'm not trying to scare you into using condoms. This is a very high yield video. Sexually transmitted infections are easily a 5-star topic, and urinary tract infections are probably a 4 to 5-star as well. Let's look at the table in your study guide and review 3 vaginal infections: bacterial vaginosis, vaginal candidiasis, which is fungal, and trichomoniasis, which is protozoal. Bacterial vaginosis, or BV, is caused by the bacteria Gardnerella vaginalis, which is a normal component of the vaginal flora. But if the normal flora gets disrupted, you can have overgrowth of Gardnerella. On exam, you'll see a thin, white, grayish discharge that coats the walls of the vagina, and the discharge has a characteristic fishy odor. And if you test the pH of the vaginal fluid, it'll be high, greater than 4.5. Normal pH is about 4 to 4.5. On wet prep, you'll see clue cells, which are vaginal epithelial cells that look like they have a bunch of little dots on them, and those are actually the Gardnerella bacteria. If you add KOH, potassium hydroxide, to the slide with your smear of vaginal fluid and then take a whiff, it will smell fishy. This is called a positive whiff test. The treatment for BV is metronidazole or clindamycin. Next is Candida. These are yeast infections, and the most commonly because of Candida albicans, but it could be other Candida species as well. This causes a thick white discharge that looks a bit like cottage cheese. This can also be quite itchy, so if you may see excoriations. The vaginal pH stays in the normal range, 4 to 4.5. On wet prep, you'll see yeast formations, including budding yeast and pseudohyphae. And then for treatment, you can use azole antifungal like fluconazole or nystatin cream. And then the last one is Trichomonas vaginalis. This protozoan that is sexually transmitted. Trich can cause a frothy yellow-green discharge with a fishy odor. The pH is often high, above 4.5. And when you look under the microscope, you can actually see these guys moving around on the slide. They're pear-shaped and sometimes have little flagella. Trichomonas can also infect the cervix, causing cervicitis. And when you do a pelvic exam with the speculum, you'll see tiny punctate hemorrhages on the cervix, which may make it look like a strawberry. This is called strawberry cervix. And the treatment for trichomoniasis is metronidazole. Let's talk about sexually transmitted infections, or the STIs. We prefer to call them sexually transmitted infections rather than sexually transmitted diseases, because a lot of time people are infected even though they don't have any symptoms or disease. The most common STI is condylomata acuminata, or genital warts. These are caused by human papillomavirus, most commonly type 6 and type 11. Do you remember which types of HPV are high risk for cervical cancer? Type 16 and 18. All 4 of these can be prevented by the quadrivalent HPV vaccine. Histologically, the hallmark finding of HPV infections is choriocytosis, which means the cells have a perinuclear cytoplasmic clearing. This little clear space around the nucleus indicates HPV infection. Let's move on to gonorrhea. This is caused by Neisseria gonorrhea. In women, gonorrhea can cause cervicitis or urethritis, which are usually asymptomatic unless it progresses to pelvic inflammatory disease, or PID, which we'll talk about separately. So most of the time in women with gonorrhea don't have any symptoms, but men are more likely to have symptoms. You can get a urethritis that can cause dysuria and a mucopurulent urethral discharge. Men can also get epididymitis, which is pain and swelling in the testicle, usually only on one side, and then rarely you can see disseminated gonorrheal infections. And remember, with disseminated infection, you may see gonococcal arthritis. So if you see a monoarticular arthritis in a young, sexually active patient, think about disseminated gonorrhea, especially on your boards. Frequently, we see gonorrhea simultaneously with chlamydia, caused by Chlamydia trachomatis serovirus D through K. Chlamydia is most common bacterial STI because, again, chlamydia is usually asymptomatic, so people are unaware they are infected and they unknowingly pass it on to others. In women, chlamydia usually infect the cervix, leading to cervicitis, but it can also cause urethritis or dysuria. And like gonorrhea, chlamydia can also lead to PID. In men, chlamydia causes urethritis, epididymitis, and prostatitis. Chlamydia is also associated with conjunctivitis from direct inoculation of the eye with infected genital secretions. And what do we call the triad of uveitis plus urethritis plus arthritis? Can't see, can't pee, can't climb a tree. That's reactive arthritis or Reiter syndrome. And chlamydia is one of the most common causes of it. Chlamydia trachomatis cerevisiae L1 through L3 cause something called lymphogranuloma venereum. This starts as a painless genital ulcer followed by extension into the lymph nodes and lymphatics, leading to painful inguinal lymphadenopathy. These swollen, painful inguinal nodes are called buboes, and they can rupture. What other sexually transmitted infections cause genital ulcers? One is HSV, herpes simplex virus. HSV1 is more commonly associated with cold sores of the lips, and HSV2 is more commonly associated with genital herpes, but you can get either one either way. Herpes causes multiple vesicles on an erythematous base, and they're painful. And eventually the roofs come off these vesicles and they erode and become shallow ulcers. With primary herpes infections, when you're first infected, it can cause systemic symptoms such as fever, headache, malaise, and myalgias, but then recurrent outbreaks tend to be less severe. Another genital ulcer is called a chancroid, which is caused by Haemophilus ducreyi. Don't get this mixed up with chancre when you see primary syphilis. This is chancroid. Chancroid is a painful genital ulcer, often accompanied by painful inguinal lymphadenopathy. With chancroid, patients often get multiple genital ulcers. These ulcers have distinct borders, and you may see a purulent exudate. Remember, chancroid, the ulcers are painful. Very important distinguishing characteristic. Haemophilus ducreyi is a gram-negative rod, and when you look at it under the microscope, it may have what is classically called a school of fish appearance. These long, parallel strands of bacteria is supposed to look like a school of fish. I guess, not really. Chancroid gets its name because it looks like a chancre of syphilis, but don't get them confused. Syphilis is caused by a spirochete, Treponema pallidum. Primary syphilis is characterized by a painless genital ulcer called a chancre. The edges of the syphilis chancre are raised or indurated, and remember that chancres are painless, so that's primary syphilis. Secondary syphilis is a systemic infection, so you can see systemic symptoms like fever, headache, malaise, and generalized lymphadenopathy. Pretty non-specific stuff, but also remember they'll have a rash and condyloma lata. The characteristic rash of secondary syphilis is a rash on the palms and the soles. That starts as erythematous macules, but then progresses to papules. And then condylomata lata, which are wart-like genital lesions which are flat, smooth, and often moist, unlike condylomata acuminata or true genital warts. In tertiary syphilis, you can see neurosyphilis, which indicates CNS involvement such as tabes dorsalis, Argyll-Robinson pupil, and sometimes dementia. You can see cardiovascular syphilis like syphilitic aortitis and gummatous syphilis, which is characterized by the formation of gummas, which are granulomatous lesions of the skin. So to sum up this section on STIs, which STIs cause genital ulcers? Lymphogranuloma venereum and the chancre of syphilis both cause painless genital ulcers. And the chancroid and genital herpes cause painful genital ulcers. Let's talk about pelvic inflammatory disease, or PID. PID is an ascending infection of the upper female reproductive tract. Infection of the uterus is called endometritis, infection of the fallopian tubes is salpingitis, and infection of the ovaries is ophritis. Sometimes the tubes will become blocked with fluid, and that's called a hydrosalpinx. If you get formation of an abscess, that's called a tubo-ovarian abscess. And sometimes the infection can spread to involve the liver capsule, and that's called Fitzhugh-Curtis syndrome. So Fitzhugh-Curtis syndrome is extension of PID to involve the liver capsule, resulting in inflammation and adhesions. This is a laparoscopic image from a patient with Fitzhugh-Curtis syndrome. And these stringy-looking things are adhesions running between the liver and the abdominal wall. These are sometimes called violin string adhesions, and that's Fitzhugh-Curtis syndrome. Where does PID come from? Remember, it's an ascending infection. Normally, the cervical mucus blocks bacteria from entering the uterus and the upper reproductive tract, but certain organisms like gonorrhea and chlamydia are able to get past that barrier, and they break down that barrier and allow some of the normal vaginal flora to ascend as well. So, PID is considered a sexually transmitted infection, but it is also polymicrobial. These patients will present with pelvic pain and lower abdominal pain, and on exam you may see mucopurulent cervical discharge. They'll also have cervical motion tenderness, which means as you do your bimanual exam and manipulate the cervix, it's really painful. This is also jokingly called chandelier sign, because if you touch the cervix and pain so bad that the patient reaches up to grab the chandelier to get away from you. We treat PID with broad-spectrum antibiotics since this is a polymicrobial infection. Because PID can be really severe and dangerous, patients who aren't treated properly are at increased risk for the complications due to inflammation and scarring, such as infertility, chronic pelvic pain, and ectopic pregnancy, because the fertilized zygote can't make it through the scarred fallopian tube and implant in the uterus, so it just implants in the tubes. So definitely know that PID is a risk factor for ectopic pregnancy. Let's talk about urinary tract infections, or UTIs. This usually occurs because of fecal flora, especially gram-negative rods like E. coli, and are transferred from the GI tract to the GU tract. An infection of the lower urinary tract is called cystitis, or what the general public call a bladder infection. An infection involving the upper urinary tract, ureters, and kidneys we call pyelonephritis, and that's usually more severe. UTIs are much more common in women than in men. Because the female urethra is so much shorter and there's less distance for the fecal flora to travel from the urethral meatus to the bladder. You also see UTIs in infants and children with certain anatomic abnormalities, such as vesicoureteral reflux, when the urine moves backwards from the bladder up to the ureters. And you can diagnose this with a radiological study called a voiding cystourethrogram. Urinary tract obstruction is another high-risk factor for UTIs. This could be from BPH in older men, or urinary tract tumors or stones. Patients with indwelling catheters are at very high risk for infection because you're giving that bacteria a path right into the bladder. And then you can get UTIs with bladder dysfunction and urinary stasis, like with a neurogenic bladder from diabetes or spinal cord injury. So urine doesn't just get flushed out as frequently, and the bacteria are able to overgrow. There's an increase in UTIs during pregnancy. And finally, immunosuppression is a risk factor for UTIs. How do UTIs normally present clinically? Well, cystitis causes dysuria, which is painful urination. Frequency and urgency can cause suprapubic pain and possibly some hematuria. And then with pyelonephritis, you can still see those same cystitis symptoms, but you may also see severe systemic symptoms as well, like fever, chills, nausea and vomiting, flank pain, or back pain. And then on physical exam, pyelonephritis may cause costovertebral angle tenderness. Beyond a history and physical, a urinalysis can help you confirm the diagnosis, and you're likely to be asked to interpret a UA on step 1. What would you expect to find with cystitis? You'd expect to see evidence of bacteria in the urine. You can also see pyuria, or white blood cells, in the urine. So you can look for leukocyte esterase, which is a marker for pyuria. Leukocyte esterase is an enzyme that the leukocytes produce. So if you have a positive leukocyte esterase, that means you have leukocytes in the urine. And then you can also look for nitrites. A positive nitrite test indicates the presence of Enterobacteriaceae, the family of bacteria that includes E. coli and other gram-negative rods that frequently cause UTIs. These bacteria convert nitrates into the urine nitrite, and so a positive nitrite test indicates the presence of those bacteria. And then you may or may not see red blood cells. What you definitely will not see with cystitis are white blood cell casts. Remember, cystitis is an infection of the bladder in the lower urinary tract, but casts are formed in the tubules and the collecting ducts of the kidney. White cell casts form when there's infection or inflammation of the kidney. Neutrophils migrate to the site of infection and they get incorporated into these casts and they end up in the urine. So, if you see white cell casts, you need to think about pyelonephritis. And then, what else would you see on a UA with pyelo? Pretty much the same things you'd see with cystitis: bacteria, white blood cells, leukocyte esterase, and nitrites, possibly some red blood cells. This is a microbiology lecture, So let's talk about the organisms that cause UTIs. E. coli is by far the most common cause and is responsible for something like 80% of UTIs. But also think about gram-negative rods like Proteus mirabilis, Klebsiella pneumoniae, and Enterobacter species. And one gram-positive you should know is Staph saprophyticus. This is the second most common cause of UTI in sexually active young women. And then there are some less common causes like Serratia marcensis and Pseudomonas, which are more likely to occur in hospitalized patients. And let's briefly talk a little bit more about Proteus mirabilis. This is not a super common cause of UTI, but it does tend to be seen in complicated cases, and it has some unique features that tend to show up on boards. Proteus is a gram-negative rod, and it is motile, and you may see it described as having a swarming motion. And Proteus produces an enzyme called urease. Urease hydrolyzes urea in the urine to form ammonia, and this raises the pH of the urine, making it more alkaline, which can precipitate the formation of struvite kidney stones, which are stones composed of magnesium, ammonium, and phosphate. When these struvite stones form in the collecting system of the kidney, they tend to fill the renal pelvis and branch into the calyces. So the stone ends up looking like the antler of a deer or stag. This is why they're called staghorn calculus. Now, Proteus isn't the only bacteria to produce urease. Klebsiella can do it too. So if you see a staghorn calculus or struvate stones, think about urease producing bacteria like Proteus or Klebsiella. Now it's time for the end of session quiz. First question, which infection matches up each of the following description? Green, frothy, vaginal discharge with flagellated cells on wet prep. That's Trichomonas vaginalis. Coeliocytes on biopsy of a lesion. Condyloma acuminata due to HPV infection. Multiple tender vesicles which later become shallow ulcers. That's herpes simplex virus. Painless genital ulcer followed by rash that involves palms and soles. Syphilis caused by Treponema pallidum. A mucopurulent cervical discharge with cervical motion tenderness. That's pelvic inflammatory disease, most commonly caused by gonorrhea and chlamydia. Next, what are the symptoms of cystitis and what are the symptoms of pyelonephritis? Cystitis causes dysuria, frequency, urgency, suprapubic pain, and possibly some hematuria. Pyelonephritis causes those plus systemic symptoms like fevers, chills, nausea, vomiting, flank pain, and costovertebral angle tenderness. And the last one, what are the urinalysis findings that would help you confirm the diagnosis of cystitis? That would be bacteriuria, pyuria, hematuria, leukocyte esterase, nitrites, and you would not see white cell casts. We also have some rapid fire facts here, guys. Strawberry cervix suggests Trichomonas vaginalis. Clue cells are those stippled or dotted epithelial cells that we see on wet prep in a patient with bacterial vaginosis, which is caused by Gardnerella vaginalis. Now that's for this one, guys. We'll see you at the next one.
They gave me this ointment, I'm just not really sure.
Hey, welcome back to DIT TV. We're rolling out another great hour of new music, including a single from Rich Ashley.
Yeah, he just released his latest album on compact disc. Dude, have you seen these things? They're totally gnarly. The future's here, man.
I'll stick with cassettes.
Well, however you listen to it, here's Rich Ashley in stereo, only on DIT TV.
I'm no stranger to love. I knew the risk of STI, malaise and fevers, how it started out. She must have got this from some other guy. Now I have some blisters on a red base. Soon they're gonna ulcerate. Never gonna give you up, never gonna find a cure. Gonna spend my whole life with herpes. Got this burning in my pants, really painful when I dance. Dealing with this FHD has me worried. I've had this problem for so long. Recurrent outbreaks and vesicles are painful. Inside we both know what's been going on. Latent virus in my sacral ganglia. And if you ask me how I'm feeling, I'll tell you I have HSV. Never gonna give you up, never gonna live this down. Taking my cyclovir to suppress it. Gotta wear a condom now, should have done it anyhow. But I didn't and I'll always regret it. Never gonna give you up, never gonna find a cure. Gonna spend my whole life with herpes. Got this burning in my pants, really painful when I dance. Dealing with this HSV has me worried.
It's time for another warm-up. Let's get going. What are the clinical uses for cephalosporins? So for the first generation, the mnemonic is PECK, P-E-C-K. So that's Proteus mirabilis, E. coli, Klebsiella pneumonia. And then don't forget the gram-positive cocci, which is, again, the main uses for these. The second generation of cephalosporins, we're adding on HEN, so H-E-N to our PECs. And that's going to be the mnemonic. The H is for Haemophilus influenza, then Enterobacter, then Neisseria species. And then again, still the PECs. That's the Proteus, the E. coli, the Klebsiella, and that's very important. You also have an S at the end of this one as well, and that's to help you remember Serratia marcescens. And again, don't forget the gram-positive cocci. Third generation cephalosporins are primarily for serious gram-negative infections. Think of Pseudomonas and for Neisseria gonorrhea as well. And then your fourth generation cephalosporin, things like cefepime, that's the big gun. It's going to work well against gram-positives and against gram-negatives like Pseudomonas. Next, what lab finding helps with the diagnosis of giant cell arteritis? So the lab that keeps you to make that diagnosis is that elevated SED rate. But for a definitive diagnosis, you actually need to get a temporal artery biopsy. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here, and welcome to Micro by Systems 3. We're going to have a lot to cover here, so let's just dive right in. First, let's talk about congenital infections, which pass from the mother to the baby either during pregnancy or during delivery and often cause congenital malformations. The mnemonic for these is TORCHES, which isn't the greatest mnemonic in the world, but it sticks, and this is a 4-star topic, so you need to be familiar with these. TORCHES stands for Toxoplasmosis, Other, which includes parvovirus B19, rubella, CMV, HIV, HSV, and syphilis. Many of these are really only problematic if the mother has a primary infection during the pregnancy, meaning that it is the first time she's exposed to the infection in the pregnancy. And a lot of these cause the same cluster of complications like growth retardation, intellectual disability, hepatosplenomegaly, or even miscarriage and stillbirth. So let's focus on what's unique about each of these. Toxoplasmosis is caused by the protozoan Toxoplasma gondii, which is transmitted by handling cat feces, which is why we tell pregnant women to avoid the litter box. You can also get it from eating undercooked meat. The classic triad for congenital toxoplasmosis is chorioretinitis, inflammation of the choroid and retina in the back of the eye, hydrocephalus, and intracranial calcifications. The O in TORCHES stands for Other, which is technically could just be about any infection, but specifically I want you to remember parvovirus B19. In children, parvovirus B19 causes erythema infectiosum, or Fifth's disease, which is the slapped cheek rash that later spreads to the chest and shoulders. In adults, parvovirus can cause arthritis, but in fetus, parvovirus B19 likes to infect the blood cell precursors, and this can result in severe fetal anemia, which eventually leads to high output heart failure, hydrops fetalis. Hydrops fetalis is basically where the baby has fluid accumulation in different parts of the body, like ascites and pleural effusions. R is for rubella, which in children causes German measles, which is basically a mild fever with discrete maculopapular rash that begins at the head and moves to the trunk. But congenital rubella is much more serious. Congenital rubella causes cataracts, patent ductus arteriosus, sensorineuronal deafness, and other classic finding in congenital rubella is the blueberry muffin rash, although this can be seen in other conditions. Here's a neonate with congenital rubella, and you can see that he is covered with dark macular lesions like blueberries in a blueberry muffin. These are areas of extramedullary hematopoiesis. C is for CMV, which is the most common of the Torch's infections. CMV is widespread, ubiquitous virus that can cause mono-like syndrome in kids and adults. Fetal CMV infection can produce a lot of non-specific findings like jaundice and hepatosplenomegaly, but one of the more common findings is sensorineuronal hearing loss. So, if they give you a pregnant woman with a mono-like syndrome and her baby has hearing loss, think about CMV. The H in Torches is for two things, HIV and herpes simplex virus. With these two, we worry more about transmission during labor and delivery rather than during pregnancy. So how do you prevent HIV transmission from the mother to the infant? Well, the mother should be on antiretroviral therapy. And then, unless she has a pretty low viral load, you want to give zidovudine during delivery, and she'll deliver by C-section. After delivery, the infant is given zidovudine prophylaxis, and finally, the mother will need to be counseled to avoid breastfeeding. Breastfeeding is contraindicated during HIV infection because the virus is definitely shed in breast milk. Herpes simplex virus was the other H. What we're worried about here is the virus being passed to the baby through direct contact with the birth canal and vulva during delivery. Congenital HSV infection can cause a vesicular rash in the infant and possibly a non-purulent conjunctivitis with keratinitis as well. But you can also get pneumonia, a CNS infection, herpes, meningoencephalitis, or even disseminated HSV and a sepsis-like picture. So how do we prevent transmission in the pregnant women with a history of herpes? We give acyclovir to suppress the HSV and prevent outbreaks starting at 36 weeks gestation. And if that doesn't work, and the patient has either active genital lesions at the time of labor or even just prodromal symptoms, you need to do a C-section. And then the S in Torches is syphilis. We cover adult syphilis in the video on sexually transmitted infections, but here we're going to talk about congenital syphilis. Take a look at the study guide and we'll do some show and tell. Congenital syphilis can cause early manifestations and late manifestations. Early manifestations are those that occur within the first 2 years of life, such as hepatomegaly and elevated LFTs. A rash followed by desquamation of the hands and feet, so the skin of the hands and the feet slough off. Snuffles, which are copious nasal secretions and often blood-tinged. And skeletal abnormalities, which can be detected by X-ray. And then the late manifestations are due to scarring or inflammation, and they develop after the first 2 years of life. These include frontal bossing, which is a prominent forehead, interstitial keratinitis, which is scarring of the cornea and can lead to blindness, a saddle nose deformity where the bridge of the nose collapses, Hutchinson teeth, which is widely spaced teeth that are notched, especially the upper incisors of the front teeth. You can see perforation of the hard palate. You can also see saber shins, which is an anterior bowing of the tibia, so they look a bit like curved swords or sabers. So congenital syphilis can cause some significant malformations, and up to 25% of cases result in fetal or early neonatal death. So it's important to prevent congenital syphilis if possible. The next question in the study guide says, what is the treatment for syphilis in a pregnant patient who is allergic to penicillins? The standard treatment for syphilis is good old penicillin G. And even in a patient who is allergic to penicillin, that is still the best treatment. So the answer is to first desensitize the patient by giving a tiny dose of penicillin in a controlled situation and gradually building up the dose until she is no longer sensitive to it, and then give the full treatment dose of penicillin. That does turn up fairly frequent on the boards and practice tests, so make sure you know it. Now, let's review various pathogens that can cause food poisoning. In the study guide, there's this question that says, what is the most likely cause of food poisoning given each of the following statements? Let's say you have vomiting for 1 to 6 hours after eating potato salad at a picnic. That's caused by Staph aureus. Staph aureus food poisoning doesn't occur because staph infects the GI tract. That would take a few days. Staph aureus food poisoning occurs within a few hours after eating the food because of the preformed toxin. You'll see Staph aureus food poisoning when the food has been prepared and then left out unrefrigerated. That allows the bacteria to grow and produce this toxin. So the patient gets sick relatively rapidly, and it causes vomiting rather than diarrhea as the chief complaint. Let's say you have vomiting 1 to 6 hours after eating reheated rice. This is Bacillus cereus. Again, this is due to preformed toxin, but with rice, think of grains and cereals and think of Bacillus cereus. Vomiting and watery diarrhea on a cruise ship. It's most likely norovirus. This is extremely contagious. You can get it from another person, or you can get it from the food that has been contaminated with secretions from an infected person. But norovirus is infamous for causing outbreaks on cruise ships. So if you see cruise ships, think norovirus. So there are 3 pathogens that can cause vomiting as the main symptoms. Next is watery diarrhea 12 hours after eating meat or poultry from a cafeteria. This is Clostridium perfringens. Clostridium pores can survive high temperatures, so if the meat is cooked but left out for a while, then the spores will germinate and the bacteria can grow. And after they're ingested, this will cause a watery diarrhea. Let's talk about causes of inflammatory diarrhea. If you see leukocytes in the stool, that's inflammatory diarrhea. Inflammatory diarrhea is associated with the invasion of the intestine, which causes things like fever, abdominal pain, and blood or mucus in the diarrhea. This is also called dysentery. Inflammatory diarrhea 1 to 3 days after eating undercooked meat or poultry, eggs, or produce. This is salmonella. Salmonella is the most common cause of foodborne illness, and it's been associated with tons of different foods, from fruits, vegetables, but classically, salmonella is associated with raw chicken or eggs. Inflammatory diarrhea after eating undercooked hamburger meat, followed by AKI or acute kidney injury. This is E. coli 0157:H7, which causes usually bloody diarrhea and can lead to a hemolytic uremic syndrome, especially in children. That's what causes the AKI. Inflammatory diarrhea after eating raw seafood. Think about Vibrio parahemolyticus or another Vibrio species. Inflammatory diarrhea followed by ascending paralysis. Ascending paralysis should make you think of Guillain-Barré syndrome, which is often associated with Campylobacter jejuni. You can also get this from eating undercooked poultry. What about descending paralysis after ingestion of homemade canned goods? That is botulism due to Clostridium botulinum. Improper canning allows for Clostridium spores to germinate and then produce botulinum toxin. The toxin prevents the release of acetylcholine at the neuromuscular junction, producing a symmetric flaccid descending paralysis. Also, know that infants can get botulism from ingesting raw honey. The baby ingests the spores in the honey, which then grow and colonize in the GI tract. Then they produce the toxin. This leads to a constipated and so-called floppy baby. Now let's discuss osteomyelitis, which is infection of the bone. There are 3 ways that the infection can reach the bone: hematogenous spread through the bloodstream, continuous spread from an established infection source like cellulitis that spreads to the underlying bone, and the 3rd way is direct inoculation from trauma or surgery. Osteomyelitis can be tricky to diagnose. It can cause symptoms like fever and chills, pain, redness, and swelling in the affected region, and on labs you can see a leukocytosis, an elevated CRP, and ESR, but these are all very nonspecific. You will almost always see the SED rate and CRP elevation in osteomyelitis. X-rays generally aren't helpful very early on because it can take weeks for the abnormalities to show up. MRI can be useful, and you can also use a radionucleotide bone scan. But the gold standard for the diagnosis of osteomyelitis is to do a bone biopsy and culture to find evidence of bacteria growing in the bone. The most common cause of osteomyelitis overall is Staph aureus, but that's usually a good guess. In certain clinical situations, there may be a better guess, so let's look at your study guide. In a patient with sickle cell disease, the most common cause of osteomyelitis is salmonella. That's a pretty common test question too, but before you send me feedback saying how I'm wrong and Staph aureus is really the most common cause in these patients, UpToDate says specifically that in the US and Europe, osteomyelitis in sickle cell patients is, usually due to salmonella or other gram-negative organisms such as E. coli. Staph aureus is the most common cause of osteomyelitis in individuals without sickle cell disease and accounts for 1/4 of all cases in sickle cell disease. And before you start complaining that I'm being US-centric, remember that the test we're preparing you for is the US MLE. They are testing you based on practicing medicine in the United States. In Africa and the Middle East, staph is still the most common cause of osteo in sickle cell patients, but in the US, it's definitely salmonella. Osteomyelitis in a patient with prosthetic devices. You need to think about coagulase-negative staph, like staph epidermidis. Involvement of the vertebrae suggests Mycobacterium tuberculosis. When TB spreads to the spine, it's called Pott's disease, which can lead to vertebral collapse and possibly spinal cord damage. Osteomyelitis following a cat bite. This is most likely Pasteurella multocida. In an IV drug user, you're still going to worry about Staph aureus, but also Pseudomonas, Serratia, and Candida. In a diabetic with a foot ulcer, osteomyelitis is most likely polymicrobial, and it can include Pseudomonas and anaerobes. You need to cover those when choosing your empiric therapy. And finally, a puncture wound to the foot through a sneaker is classically Pseudomonas. Think of that smelly, wet sneaker, and it's going to be carrying some Pseudomonas. Let's go over a few points about nosocomial infections, which is not infection of the nose. Nosocomial infections are healthcare associated infections that you pick up while in the hospital. Remember, you'll get a question where they describe a patient who's in the hospital for one thing and then they develop an unrelated infection. They might ask you to guess what the most likely bug is. For instance, lots of patients in the hospital end up with an indwelling catheter for long periods of time, and this is a big risk factor for catheter-associated UTI. You're providing a pathway for bacteria to climb up the catheter into the bladder. And the longer the catheter remains in place, the higher the risk of UTI. The organisms that cause catheter-associated UTIs are basically the same ones that cause normal UTIs, like E. coli and other gram-negative rods. But you also have to worry about Pseudomonas and Candida. But E. coli is still the most common one. Patients with a mechanical ventilator can develop ventilator-associated pneumonia, specifically Pseudomonas or Staph aureus. You can also see aspiration pneumonia in hospitalized patients, especially with altered mental status because they aren't protecting their airway and they aspirate their gastric contents. Aspiration pneumonia is usually polymicrobial, but you especially have to worry about the anaerobes. Central lines or central venous catheters can also be infected, and that will cause bacteremia. The most common causative organism here is coagulase-negative staph, like Staph epidermidis. In surgical wounds or decubitus ulcers, you worry about Staph aureus. Patients receiving parenteral nutrition, which nutrition through an IV, like a patient with pancreatitis, which are high risk for candidal bloodstream infections. And when you see nosocomial diarrhea, think about Clostridium difficile colitis, especially in a patient that has been on antibiotics. C. diff is highly transmissible, so it's easy to spread it through the hospital. And when you have a C. diff colonized patient take antibiotics, the antibiotics kill off the normal flora and the C. diff overgrows, leading to pseudomembranous colitis. So next we're going to briefly look at the red rashes of childhood. The first one is very common and the one that you will hear about all the time in children. It's hand, foot, and mouth disease. Guess where it presents? This rash is contagious and caused by Coxsackie virus type A. It presents with an oval-shaped vesicle on the palms, soles of a child, and typically they will have vesicles and ulcers in the mouth as well. Hand, foot, and mouth is self-limited, and there's not really any treatment. Frequent hand washing and avoiding close contact with those who have it will reduce the spread among children. The next one is roseola. Roseola is due to human herpes virus 6 and is typically mild. It affects children by the time they're 2 years of age. The child will usually have rose-colored macules on their body after several days of sudden high fever. These are often greater than 103 degrees, and with fevers this high, they might have febrile seizures. We also have to think about measles, also known as rubeola. It's caused by the measles virus, so pretty easy to remember the etiology. The child will usually have what's known as the 3 C's, cough, coryza, and conjunctivitis. They may also present with the Koplik spots, or blue-white spots on the buccal mucosa. These symptoms typically precede confluent rash of measles. Parents will report that the rash started on the child's head and then moved to the body. Rubella virus causes rubella. Another easy one to remember. The patient will have pink maculopapular rash that begins at the head and moves down. Unlike measles, this rash remains discrete and leads to fine discriminating truncal rash. Scarlet fever is caused by Streptococcus pyogenes. The history is usually a patient who had a recent sore throat and fever. They will also have flushed cheeks and circumoral pallor. The child will have a sandpaper-like rash from the neck to the trunk and extremities. Although there is now a vaccine for chickenpox, this is one you should know and be able to recognize. Chickenpox is caused by the varicella zoster virus. The patient will have a vesicular rash that begins on the trunk and spreads to the face and extremities. The thing to remember is that the lesions will be in various stages. There are 4 etiologies for neonatal conjunctivitis that I want you to know and be able to recognize. They are chemical, gonorrhea, chlamydia, and HSV. Let's start with chemical conjunctivitis. These patients will have a non-purulent, watery discharge that lasts 1 to 2 days. Think of this as if there was a recent antibiotic ointment use and may have caused some irritation. With conjunctivitis due to gonorrhea, there will be marked conjunctival injection, lid swelling, and profuse purulent discharge. It lasts 2 to 5 days. Rapid corneal involvement may lead to blindness, and this one may also disseminate. Chlamydia is the most common etiology, and you'll see mild to severe hyperemia, thick mucopurulent discharge that may be bloody and last 5 to 14 days. The last one is HSV. This one presents with conjunctival injection and non-purulent discharge. You may also see keratinitis and vesicular skin lesions that lead to a disseminated infection. HSV can last days to weeks. Okay, now it's time for the end of session quiz. First question, which Torch's infection is the most likely cause of each of the following findings? Chorioretinitis, hydrocephalus, intracranial calcifications. This is the classic triad for Toxoplasma gondii. Hydrops fetalis can be seen with congenital parvovirus B19. PDA, cataracts, deafness is congenital rubella, and you can also see that blueberry muffin rash. And saddle nose, snuffles, Hutchinson's teeth, and saber shins, think congenital syphilis. Next question. An infant develops flaccid paralysis after being fed cereal sweetened with honey. Which is the most likely diagnosis? The answer is this is botulism due to Clostridium botulinum. Next, in the U.S., what is the most common cause of osteomyelitis in patients with sickle cell disease? That's salmonella. Last question, guys. A group of picnic goers develop vomiting 2 hours after eating. What's the most likely cause? Assuming this isn't alcohol related, you're going to think of preformed toxins because this is a relatively rapid onset of vomiting. So what bacteria causes those? Think Staph aureus and Bacillus cereus. So it's probably Staph aureus given that it's a picnic. But that's it for this lecture, guys. We'll see you at the next one.